Okay, while we get started, good morning, everyone. My name is Rebecca Rodriguez. Thank you for joining us. Before we get started, I would like to make a few housekeeping announcements. This meeting is being recorded. Microphones and cameras have been disabled. For attendees, please use the Q&A feature to pose your questions and comments. Speakers will do their best to address them during the Q&A portions of their sessions, or will follow up directly in the future as feasible during their times. If you have technical difficulties or need assistance during this workshop, please reach out to Danielle Joniken. The link is in the chat. Next slide. As we start the day, I would like to introduce to you Dr. Daniel Gossett. He's a program director within NIDDK Division of Kidney, Urologic, and Hematologic Diseases for the welcoming remarks today.
Thanks, Rebecca. Welcome back, everyone, to the NIDDK workshop on leveraging traditional and technological approaches to advancing data and metadata standards. What a wonderful first day we had. We heard a lot about the opportunities enabled by standardized data, the pitfalls associated with not using standards, the successes of working in collaborative environments to achieve consensus or compromise on standards, the recommendation to adopt, then adapt before creating new standards, and many insights from researchers working across the NIDDK mission. Lots of opportunities to learn from one another. Let's keep going. We have an exciting agenda for day 2. In a moment, Mr. Avinash Shanbhag will deliver the keynote on better health enabled by data. And across several sessions, we will discuss resources for data standards for electronic health records and clinical research data, how technology, particularly AI, can support these efforts, the multidisciplinary approach that is needed to make this work, and lastly, how we can build partnerships and facilitate the establishment and adoption of data and metadata standards. Next slide, please. Now let's welcome our keynote speaker. Avinash Shanbhag serves as the Executive Director of the Office of Standards, Certification, and Analysis in the Office of the Assistant Secretary for Technology Policy, Office of National Coordinator for Health IT, Department of Health and Human Services. In this role, he advises the National Coordinator and the Deputy National Coordinator on Health Information Technology Matters, provides executive direction over ASTP's Health IT Standards Portfolio, ONC Health IT Certification Program, and fosters health information technology innovation. Welcome, Avinash.
Thank you very much. Can I do an audio check to just make sure that everybody is able to hear me?
We can hear you.
Oh, thank you very much. And thank you very much for a kind introduction. Again, very glad to be here. I was like, as I was, interesting story before I get started about yesterday. I was attending a meeting and I was talking to somebody who was with me in the workshop and some other workshop, and that person interestingly made a comment that they were a dentist. So they mentioned that dentists, like the cost of treating dental related conditions was second most costly in United States. And then I was like curious and asked them like, what is the most expensive or the most costly? And it turned out to be diabetes. So as you know, somebody who's again like, you know, I came back and had to use one of those AI tools to check in about just the cost of these chronic conditions, and lo and behold, diabetes is actually the second most, at least according to ChatGPT, the most expensive being heart diseases. But again, diabetes is the second most costly chronic condition in United States, and kidney-related conditions are the sixth, according to ChatGPT. So again, huge areas of chronic conditions that you all who are here can really certainly provide support and intellect to help move the needle forward. And really, it's the area around data interoperability and just the work that all of you are doing, all the folks who are here at the workshop will really help move the progress further. So thank you again. Again, this was the first thing that struck me, and I'm sure most of you are on the call are aware of it, but I felt it was a really an eye-opener for me for the importance of the work that you all do. Thank you. So I had a set of slides that I was going to present to just talk a little bit about framing where Department of Health and Human Services can support the work that you all are doing. So just wanted to check in with Danielle if whether am I sharing or it will be shared for me through the screen.
Whatever you would like. Would you like to share them, or would you want me to?
If you don't mind sharing, that might make it easier. Thank you very much.
Sure. Yep. Hold on one second.
Thank you. Because if I share, I'm sure some of those screen sharing might interfere with the Zoom. Thank you. And if you can go to the next slide. So what I wanted to talk today was, again, as I mentioned, I looked at the workshop and wanted to make sure that all of you are aware of the work that the Department of Health and Human Services is doing in the area of data interoperability and aspects of just making sure that the work that we all do are complementary and supportive of all the really important work that's happening at institutes such as NIDDK. So what I wanted to cover through today was just give a little bit of introduction about the agency and what we all do from the department level, but then dig deeper into some of the areas where, as a department, we have focused on, especially data standards, access standards through application programming interfaces. Again, a very interesting and a very important area for us to work on. Build that standards framework to networks, and again, hopefully some of it resonates to the research networks and areas where you all work to. But again, I think building out the Lego blocks of interoperability at the department level that can be leveraged by research community. And then again, leave you with a few thoughts on how the department can be leveraged by you all to support your work. Next slide, please. And next slide. Again, just to give you a sense of what we as Office of National Coordinator for Health IT previously, now we are the Assistant Secretary for Technology Policy does. Can you just hit next? We were founded in 2004. So again, we are a recent agency in terms of the number of years, just turned 21. So as in some countries, maybe that's the age at which you are deemed an adult. So we were founded in 2004, established in statute in 2009. If you can hit the next button, please. We have a broad charge towards formulating federal government's health IT strategy. And again, as a department level, we engage with all the different components within the health and human services that connect with health IT. So that includes NIH, all the various institutes at NIH, also the FDA, the CDCs, the CMSs of the world, to just make sure that as a whole, government is building out a strategy that's supportive of the work that is done by each of the agencies. Next slide, please, or next, if you can hit the next button. So again, very exciting news. I mean, we were Office of National Coordinator for Health IT, and our charge around that, which I will talk a little bit, has not changed. But over the last year, we expanded our responsibilities as we were reframed as Assistant Secretary for Technology Policy, again within Health and Human Services. That has a very clear function to support the different agencies' data interoperability needs. So we have a chief data officer within our office that engages with all the different CDOs within the different agencies, again, to ensure that the silos of data are barriers are broken, and then again, interoperability across the different agencies, across different components. If you hit the next button. The big two pieces, which I'm not going to go a little bit deeper, that really are foundational components for ASTP. One was the HITECH Act of 2008, which really foundationally built I would say, the digitization of a health system in the United States. So that really was a $40 billion investment that was provided by government through incentive programs. And essentially, they moved from paper records into digital electronic health records that are regulated by ONC. So that was the first big push. And by now, really, that foundation has been laid down. So again, it didn't happen, like it took us about a decade or so, but that was really the basis and the foundation on which a lot of these innovative activities that we can now finally talk about. And the next big thing that really came across was the 2016 21st Century Cures Act, which was, again, an important advancement built on the foundation of EHRs. And really the big area here was the ensuring that standards were kept in place, were put in place for basic access to healthcare data. And I'll talk a little bit about how that can help propel the research that NIDDK is interested in, all your stakeholders are interested. And then, and also there was additional requirements to 21st Century Cures Act around what we call as, what you see here as Trusted Exchange Framework and Common Agreement, which is really the network level of data governance and network governance, which again is important for scaling of interoperability. So those are the two big things that have really been are foundational to the work that is possible in the future. Next slide, please. And again, this is to give you a very high level or view of where certification and certified electronic health records marketplaces. Again, I know many of you researchers leverage the EHR technologies to do ETLs, to do research. And this is to again, like, make the foundation be very clear that over 96% of hospitals and over 80% use certified EHR technology, and certification has certain virtues around standardization of data, some level of data, which I'll talk a little bit about, then standardization of access capability, which again are foundational. They may not really meet all the needs of specific researchers, but this was done deliberately to build that floor on which innovation could occur. So again, high level through the work that ONC and our stakeholders have done at the national level in US, you can consider like certified EHRs are used by most hospitals and physicians, and have that those EHRs have specific requirements that let users, so researchers and other people who have all the rights and privileges to be able to access that data. Next slide, please. And again, this is like what we do at a high level. I talked a little bit about certified EHR technologies and how certification is a process. We also work a lot on standards, which I'll briefly describe, to build out the foundation level. And then a large portion of our work is around coordination with federal and states, just to make sure that the disparate standards that are out there are some way of collectively aligning them. Again, the expectation is not that there will be one standard, but the idea is that they build on some foundational capabilities, such as like the internet has got a bunch of standards. Think of that as the plumbing. Some of the base required needs can be something that all the different stakeholders can leverage. Next slide, please. So that was kind of the foundation of like what ONC and ASTP did with terms of like getting base foundational levels at play and being available for industry, including research community, to take advantage of. What I wanted to now move towards was just talk a little about some of the areas where we have leaned in as ASTP from the department perspective, and then talk a little bit about how some of the work that has been done here is foundational, but really depends a lot on and leaves a lot for you all to kind of build off, expand, and do innovation on. So I'll start with, if you go to the next slide, start with data interoperability and how we have looked at data, and then kind of move further up. So if you go to the next slide. as you all know, I think this is being the workshop's title. I think everybody here is aware and knows the importance of health data standards, making sure that data standards with appropriate metadata and semantics are so critical for being able to leverage that data for secondary research, secondary use, whatever. So as a department, we have also focused on ensuring that we coordinate across our agencies and through standards development organizations such as the ones that you see here to ensure that there is a collective federal agency policy, federal agency use cases get brought into the standards community. That really is the place where community, both from industry, from academia, all come together to ensure that the standards are established, that everybody adopts. There's a community-based activity that everybody participates in, so that these standards are then available not only for industry to use, but then those standards then can be regulated by ASTP, ONC through our certification programs and through some of our other authorities that we have, that really through the incentive programs that many of the federal agencies have, that they can then be leveraged to meet agency goals. And those kind of duopoly of both standards that are developed and supported by communities, along with the incentives that federal agency partners such as you all, through all your grants, through other incentive programs that our other agencies are able to provide, can build that framework. And again, I know I'm speaking to the choir here because of the just the deep knowledge that all of you are having in this area. But again, just to give you a flavor, that was one of the big areas that we all work with. Even though again, our work has been foundational, but has been up to a large extent being at building up the floor and in the healthcare delivery system. But those elements can be used, are being used in research, such as like use of real world evidence, real world data in EHRs that are now being leveraged for research purposes. Next slide, please. So this is where I'll first go into like some of the places where we kind of focus into actual data elements. So as we mentioned, like I talked about like how certification builds out the base level capabilities. One of the focus areas in those EHRs that are certified is a certain set of base elements of data that are like semantically interoperable. And they are required, all the certified EHRs are required to support those. And this collection of data elements is managed by ASTP, and it's called the United States Core Data for Interoperability. It is, again, a core set. We deliberately made it small enough because, again, it's supposed to kind of meet the national needs and supported by the entire ecosystem of EHRs supporting the nation. So again, they are fairly core. But the idea here is it builds this consistent baseline. And again, an important element that I'll bring up is the US CDI data standard and data element list expands annually, and there's a public process by which anybody, including the research community on this workshop, are able to submit your desired elements, we call it, and then it goes through a public, transparent process of review, analysis, updates, comment process, and then every year in July, so we are getting ready to publish our next version, it gets published, and then those standards are available for the latest standards are available to EHR technologies to upgrade and provide. And some of the standards are base level that they are required to support. So again, it's like a growing bunch of elements that are put into our regulatory framework. And what we see is that over the years, many of the EHR technologies are interested in upgrading their systems to be able to capture and exchange the updated US CDI standards. So if you go to the next slide, it will kind of like gives you a little bit of flavor of how expansive it is. Again, I don't expect, wasn't going to go to the details of any of the data elements, but at a high level, they are really core data set. They are not meant to be at the level of a clinical trials or research that any agency is building towards, which I'll get to in a little bit, how we kind of anticipate the leveraging of this data set with really the research needs. But the expectation here is like, these are foundational things that every research, every program needs. For example, patient information, you kind of need the name, the address, demographics information, typical procedures that have been done, problems. So these are observations, lab tests. So the idea here is that for elements that are typically standard across most systems, you have EHR spitting out in the most in a consistent format, and as a user of these data elements, the users can be assured that they are meeting the semantic standards that have been applied into the US CDI. So again, what we've seen in the past over the last, I would say, since this was published and required of EHR technologies over about 7-8 years and over 3 rounds of regulatory actions, that USCDI has become the de facto minimum data set for the healthcare delivery system. So again, what that means from the research side is that if you're doing real world evidence generation and connecting to EHRs, you can rest assured that these elements are available to be accessed and then be used to manipulate into your own research data sets. Next slide, please. And again, just high level, just how these data sets through USCDI are really being leveraged across different components. This was just a flavor of how pervasive it is. So as you see on the left side with EHR functions, what it means is like that these data sets are now baked into EHRs. Right side with CMS patient access rules requiring USCDI, that really incentivizes providers to be able to capture and exchange these data elements, and then they are both available in national networks that you see, such as Care Quality, eHealth Exchange, Commonwealth. These are again large networks, including some of the research networks that are leveraging these data sets. And then they are accessible for patients to be able to access the data. So again, if you're looking at components such as the All of Us program, or getting data from EHRs and or patients using their patient data into those programs, most of them are able to exchange this core set, which is expanding over time. So again, I'll suggest that as you all work through your research agenda and data sets come into place that potentially are core, consider submitting those into the US CDI framework, which is again a public website that ASTP runs to be able to be considered so that they are available as a foundational element. Next slide, please. Excellent. And then this is again a very high level overview of we realize US CDI is a small core data set, does not cover all the variety of use cases, including the ones that you all are working for. And so that was an acknowledgement that we wanted to keep the core baseline small, but we needed to give an ability for agencies and research communities and organizations to expand on it. And we have the USCDI Plus program. And again, this is a program, and just as on the slide, as you see, we engage with agencies, primarily agencies because they are the drivers of developing program needs in your area. You are the experts in elements and data that is of interest to you. And what you see here is we have a lot of what we call as USCDI Plus programs across federal agencies. And the idea here is to build out additional data elements with the same level of semantics and constructs that USDI has. But again, these are for agency-specific needs, with the intent being that they are then a place for coordination and alignment and harmonization for the various stakeholders that are interested in these specific domains. So again, this is an area where we heavily, again, a shout out I will give to our colleagues from NCI. We've worked very closely with NCI on building data extensions on cancer-related activities that are really very critical. And again, there is some alignment between both the expansion of data sets that NCI is able to do, then that is leveraged by our colleagues from the CMS, who build out incentive programs to be able to be able to be leveraged by providers in the cancer community. I mean, again, you can see that as a exemplar of how other agencies within NIH, including NIDDK, could leverage and build out data standards that are more targeted towards your community, but at the same time not having to reinvent the wheel. Next slide, please. So that's kind of on the data standard side. Very briefly on APIs, which are really ways in which you access data. If you go to the next slide. This is, again, an area where we were asked, if you go to the next slide. Okay, thank you. And again, this is at a very high level, the basic construct here is that I think as researchers, all of you, and including me when I used to be in the research area, we all do extract, transform, load of data from EHRs to create your set, and one of and that's a pretty time-consuming and not a value-add activity for researchers. So one of the things that EHRs we were asked, and we have put into our requirements and regulations that all EHRs are building out, is an easy access to data elements. Right now, the data that is the scope of the data is limited to the US CDI, which we talked about. But again, the pipelines or the foundational pipes are there through this very standard API ways, the application programming interface standard way, to be able to access not just a single patient data, but also data in bulk. So basically a large cohort of patients, to be able to extract data much more easily, to be able to advance getting access to the data much more easily. And again, this is an area where we have focused and have put standard requirements into certified health IT products, so that that is an easy way and a standard way to access data in using modern technologies such as APIs, which are prolific and are leveraged in every other industry and are now being also leveraged in the health care space. So again, this is an area at a high level. The one, I feel, if looking at it from the research community's perspective, the benefit of these standards would be a efficient way to extract the specific data that you are interested in from getting from EHF. And again, the value being, if it's efficient, then and it is semantically interoperable, then the large portion of your research activity could be focused on the research side and less on data cleanup, data manipulation, and all the rest of the stuff that is currently a lot of that work happens. And again, there are standard APIs that are required of EHRs, but again, as we talked about, we do work with agencies to build out additional APIs that are program specific, that each agency has not only is interested, but they have actually funded through a variety of activities. So if you go to the next slide, wanted to give you a brief, like a high-level view of all the different agencies, what they have done in encouraging this FHIR ecosystem. And at a high level, what you see here, again, not going through the details, but many of our federal agencies like FDA, Veterans Affairs, CMS, CDC, they all have put into either their regulations or into their grants or their program these built out not only the support for APIs, but also expanded the data sets and access capabilities and additional functionalities through these FHIR API standard ways. And again, all this was to kind of give you a view that access to data, which is again has been, it's an important activity if you want to kind of take that data to do any more any innovative research, has been improved by making it consistent through the use of standards, and it's expanding over time. If you go to the next slide. And this gives you a way, we have something as ASTP, as you know, ASTP/ONC, we are a coordinator for all of you, all the agencies and the public. So we also coordinate, along with the data side, we coordinate through the publication of this Federal Fire Action Plan, a list of all the fire standard activities that are happening, which are actually supported, funded, and needed by federal agencies that we are aware of. It's a public asset, and if you look into it, if you go to the link to the link, you'll see that there are areas of research where again new capabilities that are focused on research are being developed, are being funded, and are supported. And again, this gives you all a perspective about what's going to come in the future, given some of the investments made by federal agencies. So again, this allows you all to, as you start building out your research frameworks, as you start leveraging the data and think about future, to be able to keep an eye out and be able to know where maybe if there's an area where you feel there is a new standard being built in the fire community, then you should be able to kind of work on it and make it mature. That's an area of interest too. But again, the idea here being this API standard through a standard called FHIR, the access to data is made much easier. If you go to the next slide. All right, so now we'll talk a little bit about networks. So we kind of I'm building out the foundation. So we kind of focused on data standards as a necessary foundation. We talked about access to data, both for healthcare delivery and research being standardized, so that it's like when the research community hits all the various different technologies out there, that you're able to do it in one consistent way to just make it efficient. The next high level I wanted to talk about was just to kind of talk a little bit about how we are our ways of thinking and what we have done to provide some level of consistency at the network level. And I think just to kind of set the stage, I think most of us or most of you who are in the research community, you know that there are various research networks that again collect and scale the ability to get access to data. And again, in healthcare delivery, there are many health information exchanges out there that are both geographically located, that scale, that provide the scaling of data interoperability for a certain region. But at the same time, these networks have difficulty in interoperating because of different governance models. I mean, the great example from a non-health IT side would be looking at the way in which we use our telephones. We have the large hubs, we can call it the Verizons, the AT&Ts, and the Sprint. Assume if they were not there, and all of us were using phones in our own unique networks that were small networks created by small groups of connectivity providers. Imagine if that was the case, then we would never be able to talk to each other, because either the scale of connecting all the small networks would be so difficult that what would have ended up happening would be that in order for us to communicate, we all would have had to be on the same network. In telephony, they overcame that through these hub models where the large aggregators like the Verizons and AT&Ts and the Sprints kind of do the aggregation and resolution of network access, and leave and make that transparent, or I should say opaque, to all our end users. So I can be on AT&T and be calling somebody who's not on AT&T, and I can trust that there is a ability for the AT&T network to be talking to a non-AT&T network, just as an example. So that's kind of like at a high level the charge that we were given. If you go to the next slide, that was a charge that was given to us as part of the 21st Century Cures Act, where really it specifically said that we needed to kind of build this level of, can think of that as not so much as a technology, but a governance and a trust framework with policies and practices so that networks are able to be communicating in both a trustable manner and through some standards. So that obviously there is a need for some standards, but the standards are at the network hub level and not at each participant. That's again a very important area. So if you go to the next slide, wanted to give you a little bit of a flavor of what ASTP has done. So we looked at all the different networks. We looked at the components of, like, how we wanted to make all the different models, participants, and exchange modes still be available, but then be able to communicate at the plumbing level, at the base level, consistently. And that's where over the last several years, we built a framework and actually an infrastructure, which I'll talk a little bit about in the next slide, which is called the Trusted Exchange Framework and Common Agreement. As you can see, it's a framework that enables all the participants who are there, the smaller components, to be able to do what they do and be able to kind of connect at the framework level, which is at the hub level, through a common agreement that is kind of part of the large hubs. And the idea here is that if everybody works on a same policy framework and have some common baseline technology infrastructure to support exchange, then all the components can connect and talk at the national level. And again, exciting news, this has gone live December 2023. Again, there are a lot of areas of work still happening here. The first operationalization of this framework was on treatment purposes. So again, I think research is an area of active interest for us in the future, and we are working with various NIH components to kind of focus on what are some of the research needs and what are some of the data and trust agreements that need to be put in place so that researchers can leverage TEFCA. So if you go to the next slide, that gives you a very high-level perspective of what TEFCA is and what's our role. So at the top, as you see, like what our role, ASTP and the government's role, is not to build out the infrastructure, but to define a very high-level policy and governance requirements so that everybody is playing by the same field. So again, this is not government building a large infrastructure for everybody to kind of leverage. It's more of building out a high-level policy framework that everybody agrees on. The next level, what you see here as QHINs, which are called, Q is the Qualified Health Information Networks. Think of them as the hubs. If I take the analogy of telephony, it would be the AT&T, Verizons of the world. They are connecting to each other, and they are connecting to each other in a seamless way through some standards that they establish. They're all private entities. We have about 9 of private enterprises who are now stepped up to become qualified health information networks. There are certain requirements that they need to follow. But the idea here is that the only connectivity that they offer is like between themselves is in a standard way, so that anybody else below that, the green and the yellow dots you see are the actual end components. Think of them as clinician practices, hospitals, research organizations. All those are really connected to these QHINs and in whatever form they do, but the expectation is there's no change there, but the only real standardization occurs among the QHINs. and then they all work under this umbrella of policy. Again, that's kind of the articulation. It's already live and been actively leveraged for healthcare delivery. So for treatment purposes, providers looking for patient data across the network is happening since 2023, and over 1 billion records have already been exchanged. So again, very exciting. There is still a lot of work to be done to clarify some of the different purpose that participants can access and provide that data. There are lots of data reciprocity and other requirements that are put in place to make sure that this component is the TEFCA as a framework is both capable of scaling, but also does scale in a very deliberate and a thoughtful and a trusted manner. Very exciting work here. Next slide. And this is just, I talked briefly, so I'll gloss over it. Again, the framework here is one is the common agreement, which is really the trust principles and policies. And then amongst the qualified health information networks is where there is a standard, think of that as the foundational pipes that they need to connect. So again, I bring that up because in research, there are research networks that are being leveraged by researchers. Research networks could fall under, that this is an area to scale if networks want to leverage real-world data coming from healthcare delivery system. And again, they can become qualified health information networks, which then place additional responsibilities and on these networks, but also they can participate at the participant level and just connect to an existing qualified health information network that takes care of all the common protocols that are needed among them, while just being able to access and use the data that is available to this network. Again, this is an important way of scaling at the national level to ensure that things that are built on standard data through standard access protocols then are also leveraging at the network level if these capabilities are needed. Again, these are not, they're built, they're complementary to each other, but again, there are multiple doors and different use cases and or needs can leverage them. But again, they are not specific to any specific use case. These are think of them as foundational elements. The Internet of healthcare is what I see it as. Like this is like the base level foundational components on which you all who are really kind of focused on your own specific domain and are the experts in your area can build on based on this. And again, as you start building, you find things that need to be updated at the foundational level to support some of the key capabilities those are the things that are of interest. For example, as I mentioned as we were building the API standards, one of the key things we heard from the research community was a desire to make the extract, transform, load, the ETL process much easier through an API mode. And we kind of put that into our standards regulations of creating what we call as a bulk access of data from EHRs. At the network level, there are, again, a variety of research-specific interests that we will have to work to kind of build out at the policy level and or at the infrastructure level for the QHINs, the hubs, to be able to support. But very excited and exciting work for you all to be aware of and take advantage of in the future. So next slide, please. So I am coming to the end of my kind of like high-level connection and just talk. Again, hopefully you realize that the department is very supportive of making sure that data interoperability that you all are doing, the hard work that you all are doing at your research, discovery, and or secondary use is able to be done as efficiently, as effectively as can be done. I think. So if you go to the next slide, this was a high-level picture of like how we see the work that we do in complementing your efforts, and the workshop is both very timely and appropriate. I mean, I think like as I was thinking about it, for folks who are like, again, like I date myself by thinking about the Moore's law of compute, and like, how that law kind of expects like, computational power to be doubling every so often, every 18 months, I think was the Moore's law. I see Moore's law in the data side just starting. I mean, and really what we are seeing here with the ability for large data to be then accessed, building out through Moore's law and expanding this data through semantic interoperability could be leveraged really well by AI systems. I know it's a very exciting frontier that we just about begun, and it's something that you all, through all your efforts, are just about building out the framework for ensuring that research in your area can be leveraged. So again, at a high level, the way we kind of see our role is NIDDK, your programs, other programs, set priorities for data needs that are like specific, that build out on the foundations, but really are focused on your domains. But because it is built out from the foundations that department can support and has supported, it hopefully is built in a way such that as a research community, you are able to not only take advantage of the research data that has been collected, but are also able to tap into this huge data that is available through the real world data that is available through healthcare delivery system. You are able to take data very easily from other components of data generation, such as the claims data, the data, the administrative payer data, and just be able to mash it together through using advanced technologies, such that you are able to ultimately be able to move forward and really deliver on the promise of research and into improving patients' lives. Again, as I kind of started my talk with, like the chronic condition that really is front and central to again y'all's work, to making sure that the cost and improvements to life and patients' health from ameliorating these chronic conditions are addressed as quickly. We are all in a we are all in a great place now with just being able to unleash some of the benefits of these new advanced innovative technologies such as AI, which isn't really like, which needs, I should say. I shouldn't say couldn't be possible. I would say it really builds out and needs the support of standards, data standards, and interoperability standards and access standards that you all are working towards. I know this workshop, when I looked at the agenda, it's a lot of hard work that you all are engaging towards, but it's a necessary thing, and I'm really would like to commend NIDDK and especially Dr. Veeraswamy and Dr. Rebecca Rodriguez for again getting together and working with us and building out this workshop to bring collectively bring together all the experts to focus on being able to leverage data and standards for moving research. So very exciting work. I feel, Phil, we are right at the beginning of the start of the new Moore's law on using data and leveraging data in ways in which we can really make advancements very quickly, very efficiently, and at the same time really innovative work. So thank you again. I hope I have given you a very high level overview of the ways in which the department is thinking about. But again, I'll end up with saying that the work that we do is to break data silos, to make sure that your data needs are building off, are done as easily as possible in a way that is complementary to some of the work that research community and some of my colleagues from other agencies. I saw in the agenda, we have like a shout out to my colleague, Denise Warzel, who's spent years working on building out a semantic and a metadata infrastructure to support the data harmonization work and semantic interoperability of research data. So again, great work. Looking forward to seeing some of the fruits of your labor in the future. But thank you for standing on this journey and moving forward. Thank you.
Avinash, what an excellent talk and beginning of the day. We have a couple of questions for you on the chat. I wanted to bring them up to you. So we have a couple of minutes for a Q&A. And there's one question, is what accomplishments have been made in having EHR systems share data between each other? If you have any comments on that.
I mean, it's happening every day. I mean, it's not like a success. I would say like every day we hear stories about patients going into one provider setting and then they get referred to another clinician and data goes seamlessly from one system to the system. So again, this is happening daily. And interesting, I would say the other side of being in government is we don't hear a lot of stories about of all the things that are happening well. We only hear about when things don't work well. And in a way, it's really important that we hear about those things, because when we see things are not working as well, that's when we can kind of figure out what needs to happen. So as an example, I will say flip side to that would be, I talked a little bit about how access to patient data, lots of patients' data through this bulk capability is very important, and people are using it. Just like, you have hospitals and agencies leveraging it. We are now facing an interesting challenge around performance. There is now a increasing need for sub-second performance of this data to be brought back into the research or into any other, like, the consumer side. So that's an area of I would say, challenge, and at the same time, like, we see like there has some value and interest among the user. Another area I recently read as a data brief was patient access to their individual data has increased substantially. And that is really important, because patients engaging in their own healthcare and being able to kind of access their data through portals, through apps, third-party apps, and that has skyrocketed over the past 4 years. And really that makes, like, our analysts, when they looked at it, they found that this access has helped them be more engaged in their own treatment, own plans, and taking care of themselves. So I would say access to data, engagement by patients, and just we see, like, as I was mentioning, within the network, TESCA network, over 1 billion records have been exchanged. They are the treatment purposes only, but that is an important kind of, like, a barometer of how industry and how EHRs are exchanging amongst themselves through networks and through all these standards to kind of treat patients and really improve the healthcare outcomes for the people here.
Yeah, it definitely sets the stage, and throughout the day, we're going to see other talks that are going to talk about it. And definitely you have set the stage, and it's what we wanted, of course, to have these technological advances and also traditional approaches on how we use and leverage these technologies to set the standards for data and metadata standards. So thank you so much. There's also another comment on the chat, but I would like for the speaker, if you can unmute and maybe perhaps put your, bring out your comment, Shankar.
Yeah, thank you so much, Rebecca. And Krishnakant, thanks so much for your talk. I had a number of issues which reference to your things. Number one, is USCDI data in a relational database format, or is it in some kind of a free format? Are the data elements in the model based on well-defined ontologies or controlled vocabularies, or they are just, I know some elements you cannot do with the structured vocabularies, but others you can. And third, do you have physician, healthcare worker user interfaces that can help upload these data so that it can be in structured, well-defined formats? And how can users access your APIs? I mean, your APIs are interesting and useful, but how can they access it? And FHIR APIs will depend very critically, as you know, on the type of data and how they upload the data. And how do you make it generic? I mean, how do you make people use FHIR APIs in a way? And lastly, do you mandate a requirement for EHRs which will make FHIR APIs work? And do you have guidelines for institutions to adopt TEFCA? These are all kind of questions / comments for you to think about. I'm sure you don't have answers to all of them. It's the nature of the beast.
Do I have, how much time do I have? I'll start. No, great question. So I'll go through like based on what I remember the order, but I'll start with your very basic question of like, how does this all become real? You know, like this is your basic question. Like we got all the standards. How does it become real? And I'll start with my first section of it, which was certification. So what you see is we don't build APIs. We are ASTP is think of it as a data policy organization. So APIs are standards, and USCDI is a standard that has been put into a regulation for certification of electronic health records. And these certifications are then being used by all the private sector EHR technology, a majority over, I would say, the incentive for EHRs has been the CMS incentive programs promoting interoperability with others, which require providers, clinicians to use them. So to answer your very high level question, these APIs are right now available in provider setting around 90% of hospitals, 80% of office physicians. So they are available. So again, these are all like, if you are a provider organization, you have an EHR, I would suggest like talk to them, and they are required to provide those APIs. They're available to you all both as a single patient query and as a bulk. USCDI is a good example, how we see USCDI and how it builds, because we talked a little bit about like databases and implementations. USCDI is by definition a data policy goal. So what we put in is like high level data, like definitions and semantic binding. So if you say like, we'll pick about say problems, then we kind of say a problem could have a semantics of SNOMED CT code and other semantics. And we did it deliberately to kind of make sure that they can be implemented in a variety of standards or implementation. So they could be, if it's a research community, you can use it in a different research standard, put it in a different databases. So they are meant to be semantically interoperable, so that if you as a researcher get data from a hospital for problems, and then you get data from, say, a research clinical trials environment, assuming they all use USCDI, you should be able to semantically make sure that they have the right metadata and the right semantics to use it. Does that help you? So in a way, it doesn't force any specific implementation, and it was done deliberately because we realized that there are private sector enterprises that can do the databases and the way to build out technology much better than government can do. What government can do is much more at the higher level, define the semantics of it, give them the framework around what needs to be at the base level available, which is really what a lot of your workshop is also kind of working towards, is kind of using that and then taking the next step of defining specifications of exchange. And that's where the interest and consistency of it. Does it address you, Shankar? Again, I'm happy to take other things offline and give you much more perspective of how it is. I do realize from a research community, this is a lot of it is maybe perhaps a little bit of a newish thing, given we focus a lot on healthcare delivery system. But again, we are very excited in making sure that real-world data that is available through these healthcare delivery systems are available to all the research community to be able to do innovative research that you all are like experts at.
Yeah, thank you. I appreciate it. We can do offline discussions on implementation issues because I think the devil is in the implementation details. And so I'm happy to discuss later on.
Yeah, and perhaps they will be addressed throughout the day.
Yeah.
And so Avinash, if you can address also some of the ones that are in the Q&A, please do so. So now we're gonna move to the next session. And the next session is where we will discuss the advancements of data and metadata standards adoption, integration and interoperability, leveraging both traditional and technological approaches with a focus on clinical research, data, and EHR data standards. This session will be chaired by Dr. Jenna Norton. Dr. Norton is a program director within the NIDDK Division of Kidney, Urologic, and Hematologic Diseases. She co-leads the Electronic Health Care Plan for People with Multiple Chronic Conditions project and is a champion of data standards in research and patient care to improve interoperability of data to increase research efficiency and improve patient outcomes. Dr. Norton?
Thanks so much, Rebecca. Thanks for having me, and I'm honored to be here to introduce our next panel. I'll start with Dr. Iza Hafiza, who's the Director of Clinical Terminology, Development Services and Operations and Health Data Standards at the Regenstrief Institute. She manages the terminology development team and oversees end-to-end terminology development processes internally. She also leads national collaboration projects with CMS, NLM, ONC, and FDA, and participates in global initiatives with JIC, WHO FIC, SNOMED, HL7, EHDS, and HIE Europe. In the last 15 years prior to Regenstrief, Iza owned and led a consulting firm that provided informatics solutions and guided implementations in the healthcare field for multiple enterprises. Previously, Iza held a leadership position as Director of Medical Informatics at LMU and team lead of the Convergent Medical Technology team at Kaiser Permanente. As a physician by trade, informaticist, and subject matter expert in clinical terminology, she is currently working on investigating and evaluating solutions using AI in content development and change management process. Thank you so much for being here today. Please take it away.
Thank you so much. Can I share my screen? And
yes, please.
Showing.
Looks good.
Okay, great. Thank you. Good morning, everyone. And I am Iza Hafiza. I am a clinician by trade, a physician informaticist by training for almost 30 years now. I appreciate this opportunity to address you today and to talk about a subject that is very important and we have been always working continuously on to address the closing the gaps and facing the challenges and using opportunity related to data and to metadata standards for research priorities. I am currently Director of Terminology Services and Operation at the Health Data Standard at the Regenstrief Institute in Indianapolis, Indiana, and we are the stewards of Long and Newcomb. I'm planning on going over some outline today that I have it on the screen. We'll be going over some brief background on history about LOINC. Then I will be discussing some of the content areas and scope, ending with a brief tour or demo of the time allows for LOINC database and why is it a standard. Standards, what is that all about? So my work definitely today will be to convey to you that standards exist in the realm of healthcare standards, either formally or informally. The healthcare standards are the fundamental definitions to set the structures of the data that can be communicated in a wide variety of healthcare use cases, such as standards for data exchange, like transporting data from one place to another, one hospital to another, or one doctor's office to another. And the example of that standard is, of course, HL7. Another use case is the standard to convey the meaning of data. That's also called semantic standards. This ensures that when the data is exchanged from one place to another, it means the same thing at the destination as it does as its origin. LOINC, for example, SNOMED, and RxNORM are examples of such semantic standards. And while we'll be spending most of our time today on semantic standards, specifically for LOINC, I would like to have you taken home message that the standards make healthcare data more portable and understandable as they work together and in concert with each other to make that happen. Here is a brief history and background about the Regenstrief Institute and LOINC. The Regenstrief Institute structure consists and is based on 3 centers and 2 programs. The Center for Biomedical Informatics, where it's focused on improving healthcare through data. The Center for Health Services Research that works to improve the delivery and outcome of healthcare. And the IU Center for Aging Research works to improve the delivery and outcomes of healthcare. The 2 programs are one that I'm personally involved in, which is LOINC and Health Data Standards, that promote adoption of clinical data standards that enable efficient semantic interoperability, and Regenstrief Data Services, which is a facilitation of research questions from inception to clinical practices. If we are drilling down further into the LOINC and Health Data Standards program, the LOINC and Health Data Standards program has been a program of the Regenstrief Institute since the mid-90s. It serves as the local and focal point for data standards initiatives and policies across Regenstrief. It has a mission to promote the adoption of clinical data standards that enable efficient semantic interoperability. The program's vision is a world where systems get clinicians all of the information that need at the right place and at the right time. And we carry out our mission and our vision through our stewardship responsibility for LOINC and UCOM. UCOM is an acronym for Unified Codes for Unit of Measure, and it is a standard for specifying units of measure. For today's discussion, we'll be just focusing on LOINC. LOINC stands for Logical Observation Identifiers, Names, and Codes, and it was originated in 1994 and got its start at the Regenstrief Institute in Indianapolis, Indiana, and is the vision of Dr. Clem McDonald, and then he was at that time Regenstrief Institute researcher. Dr. McDonald had a vision for information technology to help clinicians make better decisions in caring for their patients. And this vision would be realized by having a universal language to describe clinical observation, which included those observations that occurred during the course of caring for patient and those observations that are a result of laboratory testings. His vision went much further when he wanted to see the interconnected health information systems that actually share data across systems rather than just within a single system, which was the case at that time. LOINC started in the US and now it's used in over 180 countries. LOINC is the official standard in more than 30 countries. And let us not forget about the translation that enabled the use of LOINC internationally. We currently have a 15+ variant in 12 languages. Everyone is familiar with the saying that it takes a village to raise a child or to run a business. And this is also true and applicable in the LOINC case. It takes a village to develop and maintain the LOINC and the database, from the LOINC team that's located in Indianapolis, Indiana, to the different committees that you see them listed here, going from laboratory to clinical, nursing, document ontology, and radiology. They are all very supporting of the development of the content, not to forget about a vibrant international user community who actively are participating in the development effort of LOINC. The scope of LOINC is definitely creating standard terminology for lab testing, for clinical observation, document surveys, and questionnaires. We have more than 105,000, and that's growing very fast. We have 4 major categories in LOINC: laboratory LOINC, clinical LOINC, attachment for HIPAA and HEDIS, not to forget about our payer and providers, and also very important survey instruments and questionnaires. And it's very important to emphasize that we have one common identifier which represents results they are clinically the same. Laboratory LOINC. The laboratory LOINC includes the full spectrum of laboratory tests from microbiology and chemistry to genetic testing, whether done routinely in the hospital or in outpatient setting, provider office, or done by a patient at their home. There are specialized tests such as those that need to be sent to other places, and other lab outside the common ground. And there are also tests that are focused on the patient type, such as whether it is a newborn human patient or a veterinary patient. There are tests to support larger goals like public health and epidemiology needs. Clinical LOINC includes measurement procedure for non-lab related tests, anthropomorphic measurements, vital signs for blood pressure, temperature, and physical exam tests and finding, procedure for radiology, interventional procedures, specialty like ophthalmology, cardiovascular procedure, and more than that. And not to forget about the clinical documents, notes, consultation, and similar records. The survey concept, we have included a lot of survey instrument. We have included questionnaires, that are very basic and used as record to report outcomes and provide the forms for assessment and symptoms, government-related forms, and not to forget about behavioral health, psychiatry, substance abuse assessment, and survey questionnaire, and note like about the copyright information that is also a part of it. Giving a little bit of history, so let's dig now into a little bit of the anatomy to have a better understanding about what concepts are in LOINC and to look at their structure and design, which allows LOINC concepts to convey meaning and standardize clinical and laboratory observation. This is very important part of the LOINC concept model. In any clinical terminology, SNOMED, for example, RxNorm, or LOINC, a concept is a unique unit of thought, and it is represented by combining a unique number or code with a name that's fully described that concept. And the name is called the fully specified name, and it is abbreviated as FSN. Now in LOINC, the concept displayed here is represented by the code 94500-6, which means SARS coronavirus 2 RNA respiratory specimen by PCR. Let's remember that the code and the fully specified name represent that concept. The LOINC code is a unique numeric code. It's permanent, and it is assigned sequentially at Regenstrief. There is no inherent meaning for the code, except that the last character is a calculated check digit, and you can tell the age of the code by its number. This is an example of the first code that was assigned in LOINC, and it is a laboratory test for acyclovir susceptibility. Once a code is officially created and released in LOINC, this is considered a good terminology maintenance practice. It will be there, it will never be removed, just for tracking. The LOINC concept is defined by 6 core parts. You have the component, which is the analyte being measured, property, which is the dimension of the analyte that's being measured, the time aspect, which is whether the analyte is measured at a moment in time or over a period of time, the system, which is the type of a sample, such as blood, urine, cerebral spinal fluid, and the scale, which is a general classification, that whether the results are quantitative, qualitative, narrative, ordinal, and so forth. And finally, we have the method. The method is the only attribute or part that is not always represented in the LOINC concept, and that conveys how the analyte had been measured. This is an example of how you put the parts together, or the 6 core parts together, and you come up with the test represented here. Like the hemoglobin A1C, it is like a mass fraction at point of time. It is measured in the blood, and the quantitative result of it is, and it's all using a method of the high performance liquid chromatography. So in LOINC, these pieces are called parts. Each one of those is part, and these parts are themselves, they have code that start all with an LP. So the
1 minute remaining.
Thank you. Long pieces, it is very important that we know they are conceptual, they are hierarchically posted, and they are also mapped to external terminology. When you put the parts together, you can get all the example that you are looking for here that explains the question of a concept. And because of the time, I would like to jump into making sure that we have more examples and more attributes that are a part of the metadata on LOINC. But the important concept about LOINC is actually LOINC being a question, and all the other terminologies are the answers. And this is what I want to emphasize, that anytime you are using LOINC, it is a question that you are asking about a test, but the result, for example, in this case, like SNOMED, it's in pound when you are asking about the body weight, or also if you are asking about, for example, the blood type, this is the code that is used for the answers is from SNOMED. You are using also LOINC in a different clinical aspect in reporting, like quality measure reporting, and it is a huge plus for LOINC. One more idea about LOINC is that the opportunity of searching LOINC in this LOINC database, it will allow you to see that we have several names for one concept, and all these are connected to one code. So we have one test that have 3 to 4, for example, names, and these names are all related to one concept, which gives it a flexibility to however you are calling that test. And if that one name is within that concept, you will have always the same concept code coming back, which allow you, depending on LOINC, from being a standard for such exercises. We will be sharing these slides at a later time, but I just want to emphasize how LOINC is defined as a standard, not only for a concept maintenance, but also of versioning and keeping up with a translation and all the needed concept, elements to make a LOINC a standard. Thank you.
Thank you so much. That was excellent. We now move on to Dr. Melissa Handel, who's the Director of Precision Health and Translational Informatics and the Sarah Graham Keenan Distinguished Professor in the Department of Genetics at the University of North Carolina, Chapel Hill, and co-founder of the Monarch Initiative. She also helped establish the National COVID Cohort Collaborative, or N3C as we know it, which she will present today. Her background is on molecular genetics and developmental biology, as well as translational informatics, with a focus over the past decade on open science and semantic engineering. Dr. Handel's vision is to weave together healthcare systems, basic science research, and patient-generated data through development of data integration technologies and innovative data capture strategies. Dr. Handel's research has focused on integration of genotype-phenotype data to improve rare disease diagnosis and mechanism discovery. She also leads and participates in international standards organizations to support improved data sharing and utility worldwide. Take it away.
Thank you so much, Dr. Norton. It's really a great pleasure to be here. Let me go ahead and share my slides. Let's see here. And let me know when I am back on my full screen.
Looks good.
Okay, great. So these slides are actually available, and there's a lot of terrific links in here for those of you who are interested at the link there below, tislab.org, NIDDK-2025. Hopefully this isn't the only NIDDK talk I give this year. So today I'm going to talk about several different aspects of transforming and harmonizing and interpreting real-world data. And so let us just start with a philosophy of mine, which I very technically call the putting the patient back together again, which is to say that we really want to understand how we can leverage multimodal data sources to understand the longitudinal trajectory of a given individual, both for precision medicine purposes as well as for a variety of research purposes. And so, as you all know, data about individuals is scattered across health systems and different types of data sources. And it's really challenging to get a comprehensive data set for each individual that could improve our understanding of health. And there are different formats and standards, which we've heard about this morning. There are also huge regulatory and legal challenges, security and technical compatibility challenges. And I could give a whole talk on each of those topics alone. So take, for example, Charlie Brown here. Charlie Brown was born in Norfolk, Virginia. Who knew? And he had his different schooling and different residences at different places during his lifetime until he enrolled in a research study sometime when he was in Davidson, North Carolina, when he was just going from being a young adult to a middle-aged person. And so we want to be able to track, all the different clinical records, insurance claims, environmental and social influences on his health, both at the point of enrollment for research purposes, but also prior to enrollment, so that we can understand how those influences affect his health outcomes and his health lifespan. So I'm going to talk today about the Center for Linkage and Acquisition of Data, which is an All of Us research program component that really aims to put the patient back together again. And the idea behind the CLAD is that there are new data acquisition methods needed to acquire and link data, and they fall into 3 different categories. One is what we call patient privacy preserving record linkage, or PPRL. And this is where we create tokens based on specific attributes of patient identifiers that are de-identified and can be exchanged and matched across systems. We want to be able to match based on geospatial and temporal linkages. And we also want to be able to tap into the incredible HIE, HIN, Health Information Networks identified linkage, where we can go out and find other records about individual patients that might be participating in our research studies for research. So I'm going to talk about all 3 of these different linkage types that the CLAD is fostering. And what you can see over here on the right is where we have, Charlie Brown, say, has enrolled in AOU during his middle-aged time point. Down at the bottom, you can see the actively contributed data that all of us is already collecting: the surveys, the genomics data, wearables data, bioassays, demographics, and increasingly more and more different kinds of data. But the top part of the diagram is all of these passively acquired data that really help us put the patient back together again. De-identified data linkages to claims data, prescription data, and mortality data. The identified data through the HIE, HINs, and all the geocoded data at the top. An important point to note here is that, when you look at actively contributed data, it's only from the point of enrollment on. But when we get this historical record, we can actually use that to do some really creative analytics together with that actively contributed data, as well as inferring missingness. So you can see between the claims and the EHR data if participants are dropping in and out of insurance or are receiving care in different places. We can actually help triangulate some of the missingness in that way. If you want to learn more in general about the CLAD, CLAD is looking to partner with other research projects, and you can reach us at info@cladteam.io. So I wanted to talk first about how do we actually work on these EHR data to make them available for research. So this is published work that showed how we could basically look across many, many different healthcare systems and understand how can we repair some of the units. And we just saw a wonderful presentation on LOINC, and there's a lot of interoperability things that I'll get to later in the talk that relate to that. But in part, some of those LOINC labs come in to the EHR data without proper units or with the wrong units. And so what you can see here on the right is where we've collected data from over 20 million patients and showing how only approximately half of the data comes in with its proper units, shown in green, a canonical unit. But those data that are not proper units or missing units are really challenging to compute over because they essentially get dropped from a lot of analyses. But by using algorithmic repair, we can actually repair those data to a large extent, shown in the blue. And so this is just showing how having a massive number of institutions working together, as was the question during our keynote this morning, we can actually help each individual site repair their own data, as well as repairing it across sites for cross-site analytics. And so this provided a 2-fold increase in usable data for labs that had units missing. Another way that we can harmonize data across different institutions is what we call macro visits. So it turns out different institutions actually describe visits quite differently. And so you can see here for different inpatient and outpatient visits at a given site that, one site might show different types of visits. And then we might want to understand like how, if one site has, for example, all those visits lumped into one visit, whereas another site will actually have them separated out as shown here. And it's really hard to, kind of do cross-site analytics if we can't sort of reconcile how visits are defined. So we came up with this macro visit strategy. This is also published, and it's essentially an augmented version of the OMOP visit occurrence table. And you can look to that publication to find out more information, but it's really helped us do kind of visit level analytics to understand what's happening at each visit in a consistent way across many, many sites across the US. So next I'm going to talk a little bit about how we're using the CLAD to participate in leveraging a QHIN that we heard about this morning, a health information network, eHealth Exchange, to acquire electronic health record data using an identified strategy. So this is a participant authorized exchange with the research purposes of use code. As far as we know, this is the first time there has been a national initiative to actually tap into the infrastructure that HINs and HIEs have using a research purpose of use code. And so just by way of example, approximately 90% of the All of Us research participants consent to share their EHR data, yet only 69% have records for their EHR data in the AOU DRC. And also getting that access to those data is expensive and fragmented. So as part of the CLAD, we get the cohort rosters and authorizations to acquire data. We send those queries and authorizations to our partner, eHealth Exchange. They send them to their health information exchange partners, and those health information exchange partners send them to their health provider organizations. And so it's this fractal strategy of going out and finding who has the records for our participants. And if they say yes, then we send them the consent form with the research purpose. And then those data come back in, and then we can reconcile those data. And I'll talk a little bit about the interoperability challenges of doing that and how we might scale this to all of TEFCA. So this is just showing an example of some of the great dashboarding work that we've done. And so here you can see FHIR data coming in through one of our sites as an example. And we see post-OMOP data metrics on the top, pre-OMOP data on the bottom, and then the FHIR data directly on the bottom. And this just sort of lets the technical team be able to assess any lossiness that we might have in the processing of these data. So we're converting in the context of the HIE, HIN work, the data from both FHIR and CCDA to OMOP for research purposes. And we want to be able to assess the quality of that data coming in at each step of the pipeline. So we've created some wonderful dashboards and metrics for assessing that quality. This is just showing an example of one of the HIE partners in eHealth Exchange, Manifest Medics, which covers the state of California. And what was really exciting about this is we sent out over 77,000 queries for participants in California in the All of Us research program and came back with 50,000 matches. So we had a 65% match rate. And so this was actually really exciting match rate. So we're getting a lot of different participants that we had not already had in the All of Us research program, as well as additional data, as I'll show you in the next slide. So this is just one example. There's not time to do a deep dive, but this is 10 randomly selected patients from that FHIR feed. This is a partnership with Cedars-Sinai, who has a really mature FHIR endpoint. And so we were able to compare their endpoint with CCDA, with their CCDA data, with the data that they originally submitted to the All of Us research program as an All of Us research recruitment site. So it's a very unique institution in having all three of those capabilities. And so these 10 randomly selected patients, you can see the data that was originally submitted to the All of Us DRC for the researcher workbench is shown in the purple small dots. The CCDA data, the Social Security standard, is shown in the blue dots, and the FHIR feed data is shown in the orange dots. And what's important to note here is that we can get a lot more current data from use of the HIE pilot process. But also we're seeing different data feeds in the different sources. And so this is still very preliminary, but we're trying to suss out, is this similar to the units example or the macro visit example? Simply challenges in how these different institutions are populating their CCDA, their FHIR, or their OMOP instance, or are there actual differences in the way that the data is structured that are leading to these results? And there is still more mapping to do as well. Wanted to talk briefly about our work on linking place-based environment and health data. So we've come up with a new strategy called the Hexagonal Environmental Linkage, or CHEL. And this links air quality, social determinants, and a variety of over 30 different data sets for environmental and social factors to a Hex3 grid, and allows this spatial linkage integration across different rasters, as shown over on the right. We've also done a lot of risk assessment because geocoding necessarily can create increased risk of re-identification. And we have determined that the Hex3 strategy is not only computationally advantageous, but it also still presents with low risk with most data sets, especially the data that we have included in the linkage in the CHEL. And so this is just an example of showing you some of the benefits of using Hex3 in rural areas so that we can do that geocoding. Over there on the left, you can see this lovely hexagonal strategy for Hex3. Over there on the right, which is commonly used in de-identified data, a 3-zip zip code aggregation. There are missing parts of the country because it's not possible to actually show participants in those regions based on low density of population. So the Hex3 aggregation allows us to have more comprehensive coverage. We also have strategies for jiggering participants if they end up in a participant population that is low even in the Hex3 context. So what about derived variables in CDEs? So I'm going to move on to another topic now, which is what do we do downstream when we're looking at our disease registries, things like, I'll talk a little bit about the CureGN project in a minute, but where we have really highly curated research data sets that have some derivatives from that real world data, but are leveraging derived variables and common data elements. And so there are many different common data element repositories, and the context and metadata within these are implied, including the mappings and provenance. So just shown over there on the right, there are over 1,800 databases, 1,500 standards, 900 ontologies, and over 23,000 common data elements, making common data elements quite common. And just shown by way of an example are several for date of birth, blood pressure, and smoking status. And so it's really hard to navigate, and it's really hard to harmonize these data. So this is just an example for CDEs for blood pressure. You can see in one case, we might have several different blood pressure measurements over there on the left. We might, have different concept IDs. We might have different stewards. There's different questions and answers. And again, it becomes very challenging to understand which one should we use. If we've not yet determined that we need a CDE, should we use one that's already out there or develop a new one? And so mapping CDEs is actually really important for interoperability. And this harks back to our LOINC discussion with the prior speaker, because a lot of those LOINC parts are in fact things that we have been working with LOINC to create interoperability for and can help us with this mapping strategy. And so there's two different types of alignment to think about with common data elements. And the first is that there's a data model alignment. Each source kind of models things differently. So for example, in one clinical research data set, there might not be a direct link from a sample to a diagnosis, where we would need to necessarily remodel that sample to a case and a diagnosis to a case to align with a source that has sample to a diagnosis. So it's important not to forget that there's a schema level alignment that's often needed. And then there's a value set alignment where each source uses different values. And this is just a very simple but very common example where one node might encode race with not reported white, American Indian or Alaskan Native, Black or African American, where another has a large number of sources, some of which, a large number of values, some of which are identical and some of which are not. And how we map these is really important. Do we map not reported to not allowed to collect or unknown? And the provenance of that is often not recorded. And so it's really important when doing analytics if you understand how those mappings were actually performed.
1 minute remaining.
Perfect. So we've developed an ingest and harmonization pipeline for clinical research data using the LinkML modeling standard. The link to the GitHub repo is there. And essentially what we do is we take the source data dictionary, we automate the generation of a schema. We then compare that schema to a target model, and then we can map the data using the LinkML data mapper. And out the other end get harmonized data. And so this has been work that's been performed for the Include and Biodata Catalyst programs. And more recently, we're working with the CureGN, which I'll talk about really briefly here. And so this just kind of shows some on the left, some of the mapping standard work with a standard called the Simple Standard for Sharing Ontology Mappings, which applies to terminological mappings as well as value set mappings. And how do we record the provenance of that so we can make these CDE mappings computable? On the right is shown some work we've been doing with CureGN, where CureGN came to us and said, how can we create common data elements for our really robust data dictionary and the variables that we've been collecting? And this is just showing, using LinkML, a clustering approach to show what CDEs do we already have in any of the repositories shown in the NIH CDE repository, which ones are overlapping with CureGN in red, and which ones are unique to CureGN, and how are they clustering so we can understand what we should be prioritizing in terms of developing new common data elements for CureGN, as well as what we might repurpose and align with that's already existing. And this is just a quick example which shows that pipeline, how we can get from different cohorts to align these different value sets and these different common data elements. This is an example from the Include program. And in the interest of time, I'm going to move on to my conclusions, which is just to say that real data is heterogeneous despite using common data models such as OMOP or BCornet and exchange formats such as FHIR or CCDA. Algorithmic repair and data quality improvement benefits from sites working together. We can really help sites improve their own data if we combine data across sites. Piggybacking research onto HIN and HIEs designed for care can efficiently scale acquisition. We are very excited in this next year to be working on scaling this to other HINs through TEFCA. So please contact us if you're interested in participating in that. FHIR is easier to transform to OMOP. I didn't have a chance to talk about this, but it is less available than CCDA from healthcare systems. And so that is the world we live in right now. The geospatial data can be linked to real-world data with Hex3 grids and still maintain privacy, giving us a great advantage in doing environmental health research. And common data elements can be semanticized, I think I made up that word, for analytic use and a priori improved standardization using the LinkML tools and improved mappings. And with that, I just wanted to thank the small army of people, in particular, Chris Mungle for LinkML, Corey Cox for the pipeline, Emily Paff and Richard Moffett for some of the harmonization examples, and Sharice Madlock-Brown for her leadership in the environmental data. Thanks very much.
Thank you. That was excellent. Sorry, I couldn't find my little stop video button or start video button. So we are on to our final presenter of the panel. Dr. David Dorr is a professor and vice chair in medical informatics and clinical epidemiology at Oregon Health and Science University, where he also serves as chief research information officer. He focuses on leveraging innovations to manage data and research and translate it into healthcare, particularly to improve healthcare quality. Dr. Dorr's interests include collaborative care, chronic disease management, and the information systems needed to support these areas. His goal is to provide the best care for older adults and those with chronic diseases through holistic, patient-centered longitudinal care management systems that track patient needs and goals. Additionally, he explores complex care management for at-risk populations and coordination of care. Expanding into clinical information needs, he emphasizes electronic health record deployment and health information exchange to enhance healthcare systems. Dr. Dorr leads the AI Governance Committee and recently launched a Center for AI-Enabled Learning Health Science at OHSU. He evaluates care management and informatics initiatives through various methodologies. His research team, Care Management Plus, has secured multiple grants from organizations like the John A. Hartford Foundation and NIH. Dr. Dorr, please take it away.
Thanks. I appreciate that. I'm gonna just share my screen here, and I will be thoughtful about time. Hopefully you can all hear me okay and see my screen now. So I was asked to talk about technology and learning health system to improve person-centered care planning. And I think if for this around standards, one of the things that we're really interested in is understanding how standards and interoperability can really drive improved person-centered care. And what we found so far, because of many of the data and interoperability challenges, data quality and interoperability challenges, that use cases are extremely helpful to understand that adequacy. And so I'll talk about some projects that we're doing in that. I'll start, however, in something that's near and dear to Jenna's heart, about the challenge of multiple chronic conditions, which obviously NIDDK, focuses on many chronic conditions, various kinds of kidney disease, and diabetes, which is actually my primary clinical effort as an internist. But people with multiple chronic conditions really have these complex healthcare needs, and often they're met in care settings with very disease-specific approaches. Combining those different approaches and altering them to make care plans more person-centered really is required to reduce that burden over time, and is a crucial both research and, to be honest, clinical care challenge we have, because it's really the combination of those multiple chronic illnesses with increasing risk for disability that drive healthcare utilization and poor outcomes for patients. So thinking differently about goals, including in the setting of people who have different kind of social needs and variation. It's very common in older adults, and it drives costs. The challenge is, how do you pull these data together to drive person-centered care planning? And the NIDDK HRQ e-care plan project that I've been a part of for a long time really does this, really tries to say, what does it take? What kind of data does it take? How can we pull these together and define this into an interoperable electronic care plan from different sites? Really, what the definition of this is trying to get more direct patient and caregiver access to data, and focus on what are the goals, both clinically and non-clinically. So what are the person's holistic goals? What are the other factors involved? What are the clinical goals? And really trying to work on systems that help prioritize and follow those goals up over time, applying the treatments that are wanted and not those that are not, and then allows coordination of care, which is crucial. And this is all from a panel that was 10 years ago, but still is crucial. And you can sort of see the status quo is very fragmented now, and we're really trying to at least get these patient data together to facilitate this kind of care planning. So different components of the care plan were defined through this process and are part of this. Who's the person? What are factors about them? What are their concerns, goals, interventions, and outcomes? So this is maybe a slightly different way to characterize kinds of data that are needed. And then how do you coordinate those over time? What this project has delivered is really a set of data elements and value sets to define the most commonly identified data that are needed, and ways to put them together that make sense to people. So we have many codes, many of which mean almost the same thing to people when they're building these care plans and goals. How do we combine them? What are the most important ones to focus on? Because there are so many codes and ways to combine them, it's really important. Use FHIR to define how we can exchange them, focusing on these specific resources, and then really build these tools that can help us understand how to exchange them. And so this is now in its second, maybe even you could say third generation. There's two applications. One's called My Care Planner, that's the patient app. One is called the eCare Planner, that's the clinician app. We have them in OHSU. They're active. I can pull them up on any one of my patients right now. And they can not only connect to OHSU, but other open FHIR endpoints at the request of the patient. So the patient can basically reach any one of the thousands of endpoints if they have a patient portal, and pull down their data and combine it and then show it in the app. So this can happen, but it's only the start of doing this. It looks a little like this. This is actually an updated one that we're working on for one of the behavioral health apps. So it's configurable. So you can get patient-reported outcomes that it can pull in. It then pulls in key information about the goals, the concerns, the medications, what I talked about. And then it shows the different sites that they can come from. The sources can be any one of many different sites. So really the idea here is this becomes a tool that is patient and caregiver directed that then can address some of these questions. One of the immediate kind of findings we have in the work that we're doing is that, you know, there is a lot of variability in these data, and the understanding of these data and trying to build systems that enable patients themselves and their caregivers who might have a variety of health literacy, how to understand them and group them according to their understanding is really important. One of the most exciting areas that we've been working on is sort of large language models to help with this, to help with the grouping and the understanding. Here we can see that there's some simpler ways to share group these and share these, which are what the conditions are doing here. They also provide different key results and also has some ability to show different outcome measures over time. And these are all dependent on how they're encoded. Here, you know, conditions are in SNOMED and ICD-10, and we have to leverage our ability to group them to pull them together. For medications, we've actually found they're pretty good, but they're only what's active right now at these sites. And so they're highly dependent on reconciliation. So in care planning, that's a crucial issue. Again, a lot of logic can be applied. It's a great research area to sort these out. Class, though, is much better than it ever used to be. And we're able to quickly sort through different classes and provide logic around that. But the history of medications and what they've been tried on in the past is a very messy space, and one that I think we haven't solved and is a good area for the future. For practitioners, this is crucial. Who do you see? What for what? And it's so hard. The data are really not as standardized as they could be. So there's a lot more to do here. These are all fake. These are fake data, although these are real providers, as you can see from my name. And then finally, how do we display these differently so people can interpret these data and understand what's missing and not? Here's a simple graph for blood pressure, and one of the patient-reported outcomes focus on depression screening, which has been important in a number of care planning models. And that's really important. So that's also the edge here of how do we visualize this, given that there's likely to be gaps and need for reconciliation across these. So to really build these out, you build implementation guide components. I didn't do this, but there's an implementation guide that's available here with all these components. You can pick up the value sets, what logic exists, and the examples here across all of these, and build them into your own apps, or the Care Planner apps are open source. You can fork them and do your own. But the question really is, and I'll sort of end on this for the group to discuss, how do you use them, right? How can you apply these into care, right? And feel good about the, or study the way to apply them into care and feel good about the results. So I'll give you two quick examples, but in general, a learning health system where organizations, both individually and together, learn about these data and its meaning, the crucial metrics about either care planning or the control of these conditions and the outcomes that matter to patients, and then generate inferences from those, integrate knowledge, and then continuously work to improve performance is really the crucial part of this. Data is such an important part of this, is what we're finding, and I'll show you. So one of our studies is funded by the NIA. In this one, we're focused on 2 clinical trials that are pragmatic, meaning they're done in routine care. One of them, the Care Transitions project with Dr. Samal, is focused on chronic kidney disease and other conditions for patients after discharge from the hospital. Mine is focused on high blood pressure and self-management using a tool. And our goal here is really to take this application and apply it and understand how good the data are for it. And we're in the midst of this right now, so we only have our first findings. But in general, what we've found so far is maybe similar to what the others have said, which is that to really use these in pulling data from different sites to add to our clinical trials when we're engaged directly with patients requires quite a bit of work to standardize the data, work with them so they can make sense of the data, and then continuously work to improve the way it's displayed and curated in the system. And an example is if you're in the hospital, you get a set of hospital-related goals, 20 or more. Those are no longer that important for the most part. Once you're discharged, there should be a new set of goals, but there's no way to detect that they're done, because once you're discharged, the EHR thinks they're gone, but FHIR can still request them, and they look active from that sense. So the context here is really important. What we're going to do with this, though, that I think is really cool, is we're just about to start enrolling patients to add to our pragmatic trials all their data that may be related to the outcomes that matter, and see if they would have changed the study, given that these studies in pragmatic trials often are limited by the data that you can get access to in the EHR. So we're looking at a whole bunch of different factors that will enable us to say, are these standard? Can we sort through, even with the data inadequacies, the value of adding different data from different sources for these, and how much does it enhance our ability to do these kinds of trials rapidly and accurately, and even add outcomes. The final thing I'll say before I end here is we also have an ASTP-ONC grant to look at behavioral health changes. So in behavioral health settings, their EHR capabilities are much more limited. And they often don't have access to the physical health EHRs if they're standalone. And so we took a set of use cases that were derived from people in behavioral health settings and around measurement-based care, like doing standard patient-reported outcomes to understand the impact of their mental health conditions, longitudinal care planning, integrating data, and then care transitions, and looked at all the challenges. And we're using something similar with those sites to say, could we provide the patient and their caregiver the data to then integrate into their care planning for behavioral health and physical health together? They've already told us a lot about the data they're missing. And the best part about this that I think is really interesting is the privacy is really important here. Especially one of our sites is actually substance use disorder, so 42 CFR Part 2, which limits our exchange of that data. The patients are actually really willing and interested in figuring out how they can exchange just what they want, which is another way that we're working to make this very patient-directed with these sort of standards. So that's very exciting, and working with another site at Arizona State that's specifically doing that. So in conclusion, I'll just say, so we have a few minutes, sorry about that, that what we would say we've learned in this particular area is even something like person-centered care planning, because of the complexity of multiple chronic conditions, that you really have to drill down into these specific use cases to understand what inferences are reasonable to make in these data, to pick up different ways of curating and filtering and displaying those data to make them more understandable, but also that they acknowledge these sort of gaps overall, so that they can be useful in this, and hopefully more to come. So thank you.
Thank you. That was wonderful. So next up on the docket, we have just a brief Q&A period. We're a little behind the time. So I guess, Rebecca, let me know if we should take the full 15 minutes or maybe cut it down a little bit to catch up.
Yeah, you will have until about noon.
Oh, okay. So we'll take a few quick questions. So I'm gonna start with one of my own as moderator's prerogative. And Isa, if you're still here and want to come back on, I'm not seeing your image. Oh, there you are. Great. Okay. Awesome. We're all here. I think we have a mix of folks in our audience, some of whom have been doing, standards-based research for a while, and some folks who are newer to the space and maybe just kind of starting to really think about how to better incorporate standards. And so I wanted to ask each of you your advice on, where those folks who are kind of just exploring this space, where do they get started? How do they get integrated? And what should they be thinking about as they embark on more standards-based work? Isa, why don't you please go ahead?
Just from a standard perspective, well, thank you for asking the question, because this is a constant actually question that we always receive, is that where do I start from? I have this amount of data, for example, how can I start standardizing, or where should I start from? Actually, the vision that we have always emphasized, and we have always, encouraged people to start from, is what do you want to end up? What are you seeing the end product? What do you want to achieve? From that perspective, you can take a step backward and start prioritizing, see the frequency of use. And I'm talking from a standards perspective. It is applicable across any HRE that you would like to work with, or any analytics that, tools for clinical decision support, for example. With the standards, it's always, what am I trying to do with my data? What is the outcome that I'm looking for? The reporting that I'm looking for? What do I have to take the result of the outcomes and I have to share with everyone else? Take that and then take your step backward and start looking at what it is the portion that you are trying to make unified and interoperability from a semantic perspective, and from perspective of a standard that is carrying this data going forward. So this is from a standard perspective answer.
So I couldn't agree more with Dr. Hafeeza. I think standards need to be fit for purpose, to your point. And for those of you who are deep in the clinical research space, especially with more cross study and AI technologies, we have the opportunity to really leverage data across different contexts, different modalities, different studies in ways that we never thought possible. And so really working together more as a community can really help realize some of those goals. And so, from the perspective of somebody who's already, deeply utilizing standards, really thinking, how do I further improve that interoperability landscape? For those that are newer to the standards landscape, it's important to recognize that you just can't go at it alone. It's a team sport. The whole purpose of standards is to enable data exchange, data interoperability, and shared analytics. And most of the people generating the data are not experts in actually standardizing it, or the downstream users. So find yourself some partners, look at what's been done. And like the example I presented for CureGN, they recognized that they needed some help and reached out to standards people to say, hey, how can we work together? What's already been done? And how can we actually analyze that that landscape to see what might be useful to standardize against versus what we might want to justify building new standards for. And so instead of just, out of the gate, saying I'm going to build a new standard, really kind of justifying to yourself when a new standard is actually needed and how do we build one that's fit for purpose.
Anything to add, Dave?
I mean, they covered it really well. I'll just say that one thing that I'd encourage you to do is not try to boil the ocean here. Instead, right, really think about what problems you want to work on, like we are for our clinical studies, clinical research studies, and really say, okay, what is the meaning of this when I know, when my team sort of identifies some of the problems and gaps in the current standards, and how can I both apply that now, and then how can I engage in ways to, improve this for the future? Because to be honest, we've seen really a lot of improvement in the data that comes from our systems and our ability to leverage that to make more meaningful insights. But often there's this gap in understanding that improvement over time. So a team-based approach to sort of give back a little bit as you have some lessons learned.
Great. And I'm going to sneak in one more question. I got permission. So there's a question from the audience. I'm going to paraphrase for brevity. Just acknowledging contributions from organizations like Apple and connecting with companies like LabCorp, and asking for your general thoughts on privatized research compared to public research in this space. And I'm going to also infer from the question, and this is my own piece to this, but how do you guys think about maybe the tension between sort of the need for standards to be largely open source and shared in order to be effective versus, I think privatized research and privatized standards, and how does that sort of connect?
I can take that one first if you like. So there's actually a couple questions in there. So maybe I'll take the second one first, which is to say that, we, especially because our team works a lot on kind of integrating existing standards, ontologies, and terminologies, it is extremely challenging when the standards are closed source. We spent, huge amounts of money and time legally to try to get the agreements in place to be able to even just map standards across different standards. So we'd really like to see funding, government funding sources better promote the creation of open standards. But I do think that has to be concurrent with, a focus on funding those open standards development efforts, right? So standards are often not considered very innovative. In fact, they're not innovative. That's the whole point. And so, how do we create sustainability around those standards is kind of an open question. So I do think there's a whole topic on that really has not yet been addressed very well in the field. As far as the private part, our healthcare system, especially in the United States, will not work without public-private partnerships. We have to be innovative. We are reliant on industry in order to do that. Industry has the infrastructure and the tools and the resources to really scale things. And the academic partners are where some of the creativity and the use cases and the needs are, and they really have to go together. And so coming up with innovative strategies, policies, funding sources, new laws, even changing HIPAA would help. We have some great needs in that space to really promote that notion in a way that's more sustainable, but also gets us to that vision of putting the patient back together again and being able to leverage all the different data sources about each individual person at the point of care and for research.
Thank you. That was really great. David, Isa, anything to add to that?
Just one thing is that we really need a lot of resources that are interested in the standard so they can put their effort into it. We support private and public, but now the move to public is very high on the agenda because we want everybody to benefit. And you will be surprised how many of the private sector, they are coming and they want to have their data publicly used. So this is a very good step toward that piece, but we need also the funding. That's also another piece that we have, that will be helpful to do. Thank you.
Thank you, guys. That was great. And I see Rebecca's back on camera, so I'm going to take that as my cue to wrap up and hand it back to our MC. So thank you guys for your wonderful talk.
Thank you.
Thank you.
Thank
Thanks,
you. That was wonderful. We will proceed to the next session, where we will discuss a hybrid approach with an emphasis on technological solutions for data and metadata adoption for achieving true interoperability. This session will be chaired by Dr. Veerasamy Ravichandran, known as Ravi by all. Dr. Ravichandran is a program director within the Office of NIDDK Division of Digestive Diseases and Nutrition. He leads NIH-wide efforts to strengthen data standards, interoperability, and reproducibility, contributing to multiple NIH biomedical data science initiatives. Ravi, I give it to you.
Yeah, I need to load my share slide. Okay, can you? Okay, thank you. All right.
Looks good.
Okay, thank you, Rebecca. Okay, for this session, my colleague from National Cancer Institute, Dennis Warshall, and I'll be sharing. To start up my presentation, it's on AI-enabled framework for a standardized data resource to support interoperability. Just 1 second. Not seeing my presenter view. Can you all see my slides?
Yes, we can see them.
Oh, okay. So the scientific research produces a lot of valuable data. The problem is too often this data is stuck in silos, hard to access or not easily connected to other data sets. So without clear data standards, scientists end up working in isolation. So no standards, no connection. So data standards are the key for interoperability. The standardized data elements, also known as common data elements. Here I call it standardized data elements for common data elements. Was common terms that helps researchers collect and share data in the same way across different studies. So this makes it easier to compare, combine, and share data across different studies, helping everyone work together more effectively. Each CDE is described using a standardized set of metadata fields like a name, type, format, value range, and stewardship to support reuse, interoperability, and integration across different platforms. So this example shows how using clear labels and answered choices, like for recording inflammatory bowel disease diagnosis, helps everyone collect and interpret the data in the same way. So there are many ongoing efforts to create standardized data resources for focusing on a specific area expertise. For example, each one is focusing on the specific expertise, and that's exactly how it's supposed to be. For example, some groups are working on standardizing data for clinical research, others for basic science, environmental science, social and economic science, etc. Each of these efforts help build strong specialized standards focusing on the scientific area that can be used across different types of research. But the challenge in case of CDE, for example, is difficulty in finding appropriate CDE resources, variability in data from different CDE sources, challenge in obtaining all CDs for data elements of interest from a single source, overlapping efforts on commonly used CDs across different platforms. So some of the questions we are getting are, is there an existing resource to find or draft CDs for specific data elements? Is there any available tool where we can upload our research plan or document where the tool in this in the API can automatically draft CDs based on standards? So the tentative solution would be to collect and compile a comprehensive list of standardized data elements, also known as CDEs, from standard resources, thereby creating a centralized, comprehensive reference CD resource for easy access. To begin bringing CDEs together, many efforts are already being made to collect them in one place. But now with the help of AI, we believe it's the right time to finally make this happen. Artificial intelligence allows us to find and bring together CDEs from many different sources more easily than ever before. And there are many steps here in the process, but the main idea here is to gather CDEs from trusted standard resources into one unified collection. So now that we brought the CDEs together, the next step is to use AI models to turn CDEs into vector embedding, a way of representing them as numbers in multi-dimensional space. This helps us build shared reference system where each CD is mapped based on meaning and how it relates to other. What's exciting is we can store the CDE in a smart structure that keeps track of complex relationships like a detailed map. As new CDE becomes available, we can keep adding them and they will automatically find their place in the system based on their meaning and connections. Overall, AI-powered embedding model helps us bring together all common data elements in one complete and organized catalog. So this catalog makes sure CDs are consistent, no matter where they're coming from, across different fields, studies, or databases. It becomes much easier to combine and analyze data from different sources. By solving the problem of data inconsistencies, the system makes CDs more useful in research and encourages better data sharing. It also allows new CDs to be added easily, keeping everything up to date as science evolves. Okay, for example, let's say we have collected a CDE called ulcerative colitis, along with detailed metadata, like its definition, ID, data type, permissible values, sources, etc., as shown in the box. We take all that information and turn into vector embedding, a special numerical format that captures the meaning of the CDEs, including its metadata. So this creates a unique digital fingerprint for ulcerative colitis, showing exactly where it fits in our system. Likewise, every CDE we collect gets its own spot based on what it means and how it relates to other CDEs, like placing pieces in a very organized puzzle. So we store each CDE as a unique point in a special digital space called vector embedding. For example, the CDE ulcerative colitis is placed in one of these points. But it's not just the name. Like I said before, we also include all the extra details like metadata, definition, data types, and more. Interestingly, and importantly, we can even choose how much information to be bundled with each CDE, depending on what's useful. So this smart system helps us place every CDE exactly where it belongs based on meaning. So when we search, it's like finding a needle, if not the tip of the needle in a haystack, with great precision. And we can even visualize how everything is organized in this space. So CDEs that are related naturally group together in the system based on their meaning and connections, even if there are millions of them. Because they are linked together through shared concept or topics, we can easily find and explore related CDEs. So no matter how many they are, we can quickly pull up any detail we need, all connected in a smart, organized way. So just like stars in the universe, we can store millions, even billions of CDEs along with the details. And with the help of GNN, Graph Neural Network, all these CDEs are smartly connected, making it easy to explore and understand how they relate to each other. Okay, let's assume that we have built a comprehensive CDE reference resource. The next question is, how do we actually use it? Let's say you have a data item that you want to standardize, or you are just checking to see if there already CDE exists that you are interested in. All you need to do is enter your data item either one at a time or in a batch. Behind the screen, our system turns each item into a special numerical format called a vector, which captures its meaning. Then it compares this to the vector in our CDE vector database to find the closest match based on meaning, not exact words. So this helps us quickly find the most relevant standard terms for our data. To align with our division of digestive disease and nutrition for focuses at the NIDDK, we tested this using inflammatory bowel disease IBD data. So rather than limiting our collecting to data fields specific to IBD, we broadened the scope to inflammation overall. We gathered inflammation-related data fields from sources like GO, ICD-10, LOINC, NCD Thesaurus, SNOMED CT, and others, compiled them into simple files, and then build a vector database to support inflammation-related data analysis. As we bring the data source related to inflammation, this shows how relationships are starting to form. For example, beginning with the biomarkers associated with IBD. The relationships between CDs are gathered using AI models that measures how similar the terms or descriptions are in meaning. The more closely related they are, the stronger the connection. Just a tabular representation of the initial layer of the CDEs that are interconnectable with these relationships. As additional CDs are incorporated, with the relationships seemingly integrated into the existing CDE network. The relationships are typically formed using a semantic similarity. So this means the system compares the text description or meaning of the CDEs using a vector embedding to identify, let's say, the similar terms, for example, CRP and C-reactive protein, or related concepts, for example, inflammation marker and cytokine, or the contextual overlap, for example, both used in IBD research. Again, the closer two CDs are in meaning, the stronger the relationship the system assigns between them. For example, here, endoscopic score is related to IBD's severe score, which is related to CRP level, which is a measure for the inflammatory bowel disease. So we keep adding CDEs and related details from different areas of science. Not all of them connect immediately, but as the vector database grows, more and more connections start to appear. So as we add more CDEs, again, relationships start to form. So if you zoom in on IBD related data elements, they group together like biomarkers, symptoms, lab tests, treatments, diet, genetics, social factors, and the environment. And they are all connected. The stronger the relationship between the concepts, that is more similar to items are, the closer they appear in the vector database. For example, dietary pattern tend to cluster closely, while clinical symptoms and biomarkers are more closely associated with each other. So as the list of CDE grows, AI can automatically organize them into related groups or clusters, as seen here. As more CDs are added, AI helps by placing each one where it fits best, linking it to related CDs through meaningful connection. Now that I have built a vector database for inflammation-related information, we can search in a smarter way. So now when you type what you are looking for, let's say here, inflammatory bowel disease, we know the drill, right? So the system turns these words into form that the computer understands and finds the closest to matching information in the database, kind of like searching by meaning instead of exact words. So as you can see, the search receives the most CDE relevant to inflammatory bowel disease from the inflammation vector database. So we have the option to view details for each CDE and to narrow down our selection based on the specific criteria. Since we are searching based on semantic similarity, our results also include related terms like Crohn's disease. And then we can adjust how much detail we can want to see depending on our details. And one thing I want to highlight is how we added additional different sources from additional details from different sources like MESH, OMIM, and NLM gene. For this added data, for example, the NOD2 gene mutation is automatically linked to Crohn's disease through these connections, forming meaningful relations in the data. Same thing is true for colitis, making the automatic connections and alignment together. The clinical trial data can also be linked to show where any trials related to the search items are associated with the Crohn's disease. Again, you know, they're all coming from the vector database, so not the relational database.
1 minute remaining.
Okay, so I'll show me the CDs or metadata, you know, metadata biomarkers for the IBD, or simply showing this whole detail for the ulcerative colitis. So now that, you know, we only see for this inflammatory biomarkers, we wanted to see whether it's also true for kidneys. Since we didn't collect for the CD specific for diabetes, it's actually for the diabetes, the results shown are those related to diabetes within the broader context of inflammation. And the same is true for the kidney as well. And the same is, since we didn't collect with the CD specifically for kidney, the results shown are those related to kidneys within the context of the inflammation. Here is another practical examples how we can use this vector embedding. For example, if the PI has a R01, he wants to convert all these data elements into CDE, simply can upload into this system. The system will convert, embed this CDE into appropriate data elements. As shown here, LLM extracts the data elements from the whole grant application and embed this corresponding CDE for this data element. And if you want to see the details for the experimental condition, you can go and see all the details. And having the unified standard resource is very helpful. We can collect this sources from different sources, and also the latest model, the model context protocol, is actually very helpful in dynamically uploading all the details from different sources, and we can use the different AI agents. By that, we can have this standardized, dynamically updated resource, which can be used for so many sources, can be helpful for any items mentioned here. And with that, I would like to thank Dr. David Soslavsky and Dr. Greg Germino. I'll stop this and we'll take the questions at the end. And now I would like to introduce my colleague, Ms. Dennis Waschel. He's a scientific program analyst at the National Cancer Institute. Dennis leads the development of the Cancer Data Standards Registry and the repository. And this system helps create and manage standardized machine-readable definitions for things like common data elements, case report forms, and the data models, all important for making research data easier to understand and use. So Dennis specializes in designing systems that make data more consistent and meaningful across its entire life cycle. She holds master's degree in computer science from the University of Oxford, and is also part of the NIH CDE governance group that reviews submission CDs for NIH. Without further ado, Dennis, it's yours.
Thank you, Ravi, and thank you for that excellent presentation. I think a very good lead into my talk. I am working from home still, and so I'm going to turn my video off just to ensure I don't have any bandwidth problems, but nice to see you all. Okay, let me share my screen. Okay. All right. Are you seeing my slide?
Yep.
Okay, thank you. So I've already been introduced. Thank you, Ravi, for that. I'm going to start my talk with asking you to think about how CDEs might fit into the world of AI. Artificial intelligence is being used for many things. I think the use case that Ravi just presented is an excellent one for the community of folks who use CDEs and try to find the right ones. But I'm going to talk a little bit more broadly about how CDEs can help with AI. And in particular, it has a lot to do with helping prepare data for use in training AI models. If you think into the future and how we might be using AI and doctors being able to find exactly that right treatment based on the latest research and information that's available and based on the patient's details, this is actually the reason I came to NCI 25 years ago from IBM, where we were using data to customize the way items were sold in a grocery store, which isn't really all that exciting. But if you extrapolate that into how you might use data to better treat patients by having access to clinical trial data at your fingertips and to be confident and sure that the information is accurate, I think is just game changing. And what I'm here to talk about is, think about if your data elements, your use of data elements is what enabled this kind of advancement in healthcare. Most people understand that artificial intelligence has a lot of potential. Training those AI models requires heavily large quantities of data, and that data needs to be very high quality and is expensive to prepare. And I believe that common data elements can play a pivotal role in standardizing this data for use in AI training and in AI applications. So just think that, you know, any of you who have tried to create a data element know that it requires a lot of effort, a lot of research. The kinds of tools that Ravi has been talking about can certainly reduce that effort in finding the data elements. My hope is that when you think about the potential that having used data elements to prepare your data creates, that you will be more motivated to try to create, use them, find them and use them, and also see more value in the time it takes you to take that extra step. So there are a lot of potential uses for AI in biomedical research, and I'm just pointing out a few of them here that have some fairly obvious benefits. In drug discovery, we have the potential for faster access to life-saving treatments. Most of the literature talks about reducing the time from around 15 or more years to 5 to 7 years, which of course can reduce costs. It can help identify new drug targets and provide better prediction of efficacy and safety even before the expensive trials start. It also can help find new uses for already approved drugs. In precision medicine, which is sort of the use case I talked about in the beginning, it can help individualize these therapies based on the patient's genetic, environmental, lifestyle, and medical history in comparisons to those people who have been in a trial on those same treatments and determine whether your patient's profile matches that of someone who had a good outcome. These comprehensive patient profiles will produce better outcomes for the patient and reduce risk. In medical imaging and diagnosis, the things that I've been reading are that people feel that it's almost superhuman, the accuracy that AI can apply to image detection for earlier detection of smaller lesions, but also now applying that to pathology images for better and more accurate interpretation. It can also make these kinds of expert analyses available in areas, rural areas where experts are scarce, because now the computer can assist in these diagnostic sessions. In fact, had that been available from my mother when she was diagnosed with lung cancer, it could have helped avoid painful and extensive pre-surgery testing if the pathologist had had access to AI imaging that could have more accurately determined whether a metastasis was the same lung cancer as the original biopsy. In this particular case, they're extending it now to radiology and trying to improve the diagnostic capabilities of radiology, where of course, that technology is less expensive and more available worldwide. And if you can get better diagnosis out of a radiograph, you're saving a lot of money and speeding up the detection. So in this case, the radiographer with 16 years experience, which is not like someone with 50 years experience, but still, you know, fairly experienced, missed the suspicious lesion. And it was later confirmed in the experiments from Dr. Park that there was in fact a lung cancer mass there. So the categories of AI, we just heard about some of them and the areas in which CDEs can help. These are broad categories of AI. Symbolic AI are things that we've been using for a long time. We used to call your nurse line, and they had sort of a rules-based engine that would help triage your situation and potentially, if not make a diagnosis, at least direct you to the right place. There are lots of other kinds of symbolic AI now that use knowledge graphs and ontologies, and this is really an area where you're looking for an exact answer. And then there's statistical and machine learning, which includes LLMs. The AI models can be trained either supervised or unsupervised or with reinforcement learning, things like classification systems, which is something like we just saw, where it can look at similarities and detect things that look suspicious. decision trees, clustering. So most of what Ravi was talking about falls into the statistical and machine learning. But more and more now, people are leaning towards a hybrid. And depending on your use case, one or the other does not have to be used in isolation, but can be combined and used in an AI model that leverages the strengths of both. Neural networking and deep learning. I'm not going to talk much about how CTEs can help in that environment. They probably can. These are fairly advanced based on speech and visual input and have been around a lot longer. And AI techniques have been used in those fields a lot longer. And so I will not be talking about that. Okay, so a couple of the biggest problems in AI are the quality of the data in order to train these AI systems with high volumes of data, and also the availability. So the volume aspect is making more data available to train, and the quality is in ensuring that you don't have garbage in and garbage out. A lot of time now is spent on manual data cleaning. There was a presentation, I think, from the Office of Data Science last year about the tremendous amount of time, the expertise that's required in just trying to get your data ready to train an AI model. Some of those reasons are because of incorrect labels and inconsistent terminology usage. Sometimes it's missing data validation, which creates, of course, bad data. And when you have bad data, it reduces the ability of the model to perform at its optimal level. So insufficient high quality data produces poor quality AI models. Another reason for this is the format and structure. Inconsistent data formats have been a problem for a very long time. We think the CTEs can help address this. And also heterogeneous data models where people have actually captured the same idea, but in different ways. And a simple to understand example, I apologize for my typo there, is a single field that shows the blood pressure versus two fields, one showing systolic and diastolic, in which a calculation might be needed to come up with the blood pressure. And then other things that we've seen, because data models are developed for different purposes, and rightly so, some people might capture something, this is a real example, like sexual orientation as an observation, and in another data model, it's considered a personal characteristics. We need ways for the system to understand that those are actually the same data item, and not just because they're in different tables and different data models. So this leads to a lack of interoperability, and of course that reduces the amount of data that's available to use in these AI pipelines. And the kinds of issues I'm talking about here are not simply overcome by compute logic or technology. They're generally now dealt with manual intervention, with a high amount of subject matter expertise required and time involved. And I mentioned LLM hallucinations because LLMs are such a widely accessible kind of AI now. And hallucinations, if y'all are not familiar with that, I'll just touch on it briefly. It's where it's factually incorrect. Because of the strength of LLMs and their sophisticated matching capabilities, they will predict what should come next, but it might not be correct. And so this making up of details and sounding very confident, if you're interacting directly with an AI engine, ChatGPT or Claude Sonnet, it sounds like it knows what it's talking about. That can lead to incorrect responses and people making poor decisions. So reducing hallucinations is obviously a high priority. How can we prevent it? Well, having higher quality data for AI training is one way to do that. Using data sets that have been verified and are used to augment the LLM or put guardrails around it. And some of the ways that you might do that are with retrieval augmented generation, which is RAG. RAG's benefits and strengths really are when you're focused on exactly matching, and similar is not good enough. Vector databases and embedding, as you just saw with Ravi's talk, focus on semantic similarity, which is useful depending, again, on your use case. And finding data elements that might be useful, if it's similar, that's good enough. Knowledge graphs are used in this context to provide the domain context that says those where words can be similar in different contexts. And when you provide knowledge graphs along with your retrieval or use them to build your vector databases, it can help the LLM system tailor its results to be more specific to the kind of content you're looking for. So my advice there is just simply to select the right approach based on your use case. I'm just going to briefly talk about common data elements again, but from a different perspective than what Ravi mentioned. I mean, data elements are basically just metadata. So if it's metadata, which is data, and it's describing the meaning and the format of data, there are various uses for this beyond just seeing whether data elements are similar or not. There are some characteristics that Ravi didn't emphasize that I'd like to emphasize now. of CDEs, and some of these slides were presented at a CDE workshop at the beginning of 2024. The three components here that I'm going to emphasize are the use of standard terminology concepts. And these are not just the words that you use to name your data element or to define them, they're actually links to concept codes, which are uniquely identifying the meaning of a term within any community, but in our case, we use terminologies that are related to biomedical and healthcare. This provides shared meaning, and of course that's important, but it also provides computable meaning. The other thing about CDEs, at least from the context of NIH, is that they have a standard structure, and that standard structure makes them very amenable for use in machine learning because the computer can understand that everything it's getting is exactly the same format, and it knows what to do with each piece of data because it knows what role that piece of data plays. Is it a permissible value, or is it providing the meaning of the field? And then the other thing about CDE semantics is that they are independent. A CDE has its own complete context about what it means, about what the possible data values mean, and those CDEs can be used across studies. They're not tied specifically to a data model, and that provides a tremendous advantage in terms of interoperability and designing your system so that they're interoperable from the beginning, which I call born interoperable. Reusing these CDEs across different studies has a high potential for producing high-performing AI models. A little bit more about semantics. The context is important in conveying the meaning, and words have different meanings depending on the words around it. And some of the examples are the ones you see here. Agent, is that a chemical compound or a government employee? So I'll say about that. And then another good example is mole. Is it an animal? Is it a unit of measure? Or is it a blemish? So these words are semantically ambiguous. There's lots of them, I think, especially in the English language. I'm not sure about other languages, but words can have different meanings in different contexts. And CDEs provide these links to these standard concept codes that give you a domain-specific context, which is extremely important if you're going to feed these into an AI training engine so that you can have a high-quality AI model that is domain-specific. Okay, a word about ontologies, which are a special kind of concept system, and these are very powerful. People will refer to things as an ontology that may not actually formally be an ontology. And so I just want to point out the advantages of what I will call a real ontology. I hope no one's offended by that. But they encode knowledge. And the way they encode that knowledge is in data that's actually in the database that ontology sits in, with special languages and terms and things of how to define it, which I don't want to get into. But these relationships between the concepts tell you something about that concept. I mean, you can read what a T53 gene is in the NCI thesaurus, and that's informative, but then you can look at the relationships between the T53 gene and other concepts in that ontology. And so it tells you that it plays a role in certain processes, and it can be one or more processes. So the endpoints, you have the T53 gene on the left, and then you have an endpoint for these different kinds of relationships, and it can be one or more on that other end. And so that kind of information can enhance an LLM's ability to find similarity matches. It can also help if you're trying to find something exact. You say, I want to know specifically, does this T53 gene have a role in diabetes? Well, if you're using a vector database, you might say, well, it's kind of similar. But if you really want an exact answer and you want to limit it to just the known knowledge, then these ontologies that have been loaded into your AI model can really help reduce the hallucinations and provide you with exact answers. Okay, so then some of the other characteristics of what we will call a well-curated CDE, and I've mentioned them before, but it's the machine readability, this standard format that ensures that the computers that are slurping up these CDEs can properly process them. It can also help with automating mapping and transformation, which when we try to figure out how do we get more data, train our AI model from different data sources, the CDEs and those concept annotations can help you help the system figure out that the data can be aggregated and pooled and then build you more volumes of data for that AI training. And then the semantic clarity can help again with eliminating ambiguity and ensuring consistent understanding. So key messages about CDEs and the concepts that we use and why we use them. Words can have different meaning. The use of CDEs with standard concept codes, especially from ontologies, can provide unambiguous shared meaning and in a specific context. And this is then linked to knowledge that expands the ability of the machine to either give you an exact answer, or if you prefer to have a similar answer, if you've combined RAG and vector databases with embedding, you can get a very powerful AI model that is very useful and can support many different use cases. Okay, so how does this work? So CDEs take raw data and it defines how that data should be collected, how it should be formatted, how it should be labeled and interpreted. This improves the data quality issues that I talked about before. The CDE enables the automatic semantic mapping by using the concept codes that are associated with those CDEs in a structured way. So this is increasing the availability of large amounts of data for AI training. The AI training with these concepts and knowledge systems that have been used to build the AI model then can provide AI algorithms that are using domain-specific information and enhancing your training, building a higher performing and improved model performance. So let's again summarize the ways in which CDEs can address AI challenges. It improves data quality, making the data consistent, computable, providing semantics and labeling. It structures the data collection so that the data is more valid. The CDE information can be used in data validation. And so you have unambiguous data collection methods, reducing the uncertainty and improving the ability for someone to use these CDEs in supervised learning. Increasing data availability comes from the use of common formats that can be used to create interoperability across different data sets and pooling of data sets. The rich CDE metadata with concept annotations facilitates mapping and reducing the labor for intensive data preparation that normally occurs when trying to build AI models. So you have more high quality data with less effort that speeds up the AI pipeline from AI model development and training. You can reduce hallucinations by improving retrieval quality by feeding ontologies and CDEs themselves into your AI model for training. It provides semantic grounding and enables knowledge graph integration. Contextualized CDEs for AI-based training can standardize data to support more factual results, building larger pools of data and helping to accelerate AI training and building of AI models. Okay, just a minute on future directions. What we would like to do is encourage the use of CDEs across all of the ICs, across different research domains so that they can be integrated and we can find similarities and patterns based on the concept annotations and the relationships between those concepts and different diseases. We can support interoperability across domains and increase the use of well-curated CDEs. In terms of integrating with emerging AI technologies, we want you to create, harmonize, and reuse CDEs using AI technologies in the way that Ravi talked about to help you find them more quickly, help you create new ones from the core information of existing CDEs, and help you harmonize them across studies. And then also to use them in training AI models for improved predictive analytics. And then just one point on CDEs. They're not really one and done. When you're doing science, there's always new information that's being discovered. And so we encourage that if you go down the path of finding and using CDEs, that you continue to feed back refinements and updates to those CDEs to keep pace with evolving research. For example, our biomarker data element started out with maybe 100 or 200 biomarkers with all of their different synonyms, and it's now up to 6,000. And if we had thought that we had just created the biomarker element and we're done with it, it would not have the value that it does today. So it continually is being versioned. I think we may be on version 16 or 17 of it. And so they do require your attention, especially the ones that are being used regularly in your research. And someone mentioned earlier, kind of pick and choose what standards are important. You might not need to define every single field in your data set. We would like you to, but the ones that are really key to the science need some care and feeding. Okay, so the call to action: adopt CDEs to help make your data sets AI ready, advance research, and improve healthcare. You're going to improve data quality. You're going to support more data for training your AI models, increasing data availability. And once you've done that, your AI model is going to be higher performing, and it's going to provide better data analytics. Thank you. And I think I was about on time.
Thank you, Denise. So
Thank you, Ravi.
Yeah, we can take questions. Shankar, I see a question. Can you just frame the question so everybody can listen?
Yeah, thank you, Ravi. I was talking about the fact that I really like the idea of CDEs. As you know, that's the future of harmonization will depend on people adopting common data elements in correct formats. The question I had was the cardinality of each CD element can be quite diverse. It can be higher dimensional. It can be itself a vector or a matrix, in which case it becomes very complex to really associate a CDE with a simple single vector. How do we deal with this? And one way to get around it is to build the knowledge graphs, which would have higher dimensional graphs where you can expand on each node as needed and as you can go forward. And there are ways of dealing with next generation AI as well as LLM with knowledge graph models. And that may be something to think about going forward in the future. I'm referring to, for example, if you take omics data, many omics data can be higher dimensional data. And so this is really where you may have challenges if you're going to use CDE vector-based approaches for AI.
Absolutely, absolutely. I mean, again, this is the vectorizing is a complex challenge, as you know, Shankar, especially when the CDs themselves may be vectors or matrices, right? So it's not just a simple scalar values. So what we are thinking is actually, we can define a standard representation for CDE. For example, make a numerical scale or floating, categorical embedding, time series of vectors, matrix, image, multimodal, that kind of define a standard representation per CDE. And then the second option would be to normalize dimensionality. It's like a projection layer, auto encoding or transformers, that kind of stuff. And then third will be handle categorical high cardinality. And then fourth will be metadata guiding and encoding. So again, I agree because it's a complex process, but knowledge graph with vector embedding may be a good idea. But again, it's adding additional complexity. So I thought rather we can create a knowledge graph using the vector embedding. I mean, as you know, you can also embed the knowledge graph with the vector embedding. That would be an easier option also. Yeah. So it's, Thank you.
The other related point, Ravi, if you don't mind my adding, is that CDEs have to be based on either well-defined, somewhat defined ontologies or controlled vocabularies. If you didn't have controlled vocabularies for CDEs, if you keep expanding them, because you invited the community to expand, which is good, I mean, but it has got to, ensure that it conforms to some ontology or structured vocabulary. Otherwise, the disambiguation problem will become pretty serious.
Right. Agreed. Thanks.
So just to comment on that, Shankar, that last point that you made, the metathisauruses provide mappings between terminologies. Yeah. And so, within a certain domain, when we work with people developing new CDEs, we deliberately try to reuse the same concepts for that domain. And then we rely on the mappings that are available through the UMLS to help us when we get across sources where they were using different terminologies. And so it's not perfect, but there is sort of a roadmap there for, not limiting you in terms of what you need to do for your science and forcing you to use terminology that's inappropriate, and then let you do that, but then still be able to map behind the scenes.
Thank you, Denise. I think it makes complete sense what you're saying. Yeah.
Okay, I'm not seeing many questions in this. Ravi, you did such a great job.
There are some questions in the.
Oh, okay, I'm not seeing that.
Where is it?
I'm not seeing.
In the Q&A feature, and there's some others in the chat if you want to address them. If not, I can bring them up for you.
Yeah, I can see it. Rebecca, can you just phrase it?
And so there's one about would be interested in Denise's presentation, CDEs, and how these relate to Melissa's presentation earlier. Do you see that one?
I didn't, but maybe Melissa saw her presentation and mine, and maybe she can comment on that. I'd invite her to if she's able. She may have dropped off as well. So I'm not sure. I know that Melissa does a lot of work with ontologies. If you could ask a little bit more specific question, I might be able to answer it.
So these are in the Q&A feature. So if you
how can I find
want to see them.
Oh, I see it. I see it. Okay.
Oh, the open questions. Yeah.
Yeah, so Ken, I don't know if you can, Melissa's idea of semanticized CDEs. I'm not really sure what she meant by that, but from an NIH CDE perspective, what we mean is CDEs that have these concept codes linked to them specifically to define their semantics and also to each of the permitted values. So maybe that may relate to an idea of semanticized CDEs, but she would really be more appropriate to answer that question directly. But there's another question from Tejas. The RSNA and ACR have a collaboration now for standardizing CDEs across radiology. Can they be integrated with LOINC and other? This would provide enormously useful automated reporting of AI-derived outputs and reimbursements. So yes, Tejas, we didn't really show where and how the CDEs are annotated with concepts, but you can use LOINC codes or any other standard terminology codes to help define the semantics of your CDE. And then when you feed that CDE information into a system like the one Robbie's talking about to help find similar CDEs, you know, it can be used that way because, again, the mappings from the metathesaurus that also get used in building that AI model will help you walk across these different terminology systems. And then for other use cases where you're trying to use the CDEs alongside data, it can also help interpret the data that might have been coded with different coding systems. I'm not sure if that helps your question, but.
Thank you. And we see that Esa has raised a hand.
Yes, if I can may add one more point to Tejas on the last question that has in the question and answer box. We have an MOU with RSNA and ACR. We already have RSNA implemented in LOINC, and you can download that. It is called the RSNA Playbook. ACR, we already have an MOU that's cleared just lately, and that's going to be also included in LOINC. So stay tuned for the updates. Thank you.
Thank you for that.
Sure.
So I do have a question. You know, some of these can be, obviously, some of them are better addressed prospectively. What are some of the recommendations perhaps that you will have for retrospective accommodations or implementations of these technological advances?
So let me, if you don't mind, Robbie, let me grab that first and then you can comment. We have a lot of that, even though we have over 70,000 data elements describing our research across the past 25 years. We have a lot of data sets that have not been annotated with CDEs. We did not require it of our extramural studies. And so what we're experimenting now is with taking the data dictionaries from some of these groups that do not have data elements and using a similar approach that Robbie is using to see if we can identify existing CDEs that could map to them. And so doing retrospective annotations to make them as useful in an AI framework as possible. So that is something that even the framework that Robbie talked about can help with, because most people will have some kind of data dictionary, at least a field label. Some of the experiments I've done, I've given it a field label that's pretty obtuse, but then I've added, they call it prompt engineering. I've added that, oh, this is a field name that's been used in breast cancer research on this particular kind of study and blah, blah, blah. And it came back and actually told me what it thought that field was. So the capabilities of the LLMs are really, quite astounding. But you have to provide that extra context, which would then allow us to harvest the meaning of existing data. But someone mentioned, maybe it was you, that most of the focus is on prospective data because in the past, at least, the effort to try to get the meaning of data that's already been collected has been huge, but now AI may help us with that.
Yeah, I agree with you, Dennis. We cannot just rely on manual review, right? There is always need for AI and hybrid approach like AI and then manual review after that. We cannot just rely on just AI alone or manually just rely on manual review alone.
Right. We can't just throw all the old data that was out there and expect it to understand it all. No, but it can help us with those annotations.
And just to follow up on that questions, whose role will it be to retrospectively annotate the data? Does it lay on the repositories that host those data or in the submitters of those data?
Yeah. So in our case, the Cancer Research Data Commons, the submitters are suggested to use data elements, but sometimes they don't. And then the NCI has decided we want your data, and so we have taken on the responsibility to try to harmonize their data with existing CDEs. Because our data commons have a lot of analytics built on top of them, and they require that you submit your data and that it be transformed into their format to optimize the kinds of research that's available there. Just like an OMOP database, you can't just put any data in any format into OMOP, you have to convert it into the OMOP standard. And so in our case, NCI has taken on that responsibility to take that data that wants to, that wants to be included and then try to clean it up and align it.
Yeah, I agree. It will be better for the repositories, right? They collect cumulative data. They know exactly what the kind of data getting from, where they're getting from.
Yeah.
Just
I mean,
collect in one place, yeah.
Yeah, but they have to work with the data owner. But in terms of expecting the data owner to do everything he needs to make his data usable for secondary use cases, it's just not, culturally, it's not there's no technical problem, but culturally it just doesn't seem to work. It seems to be those who want to use the data that have to lead that effort.
Well, it looks like we are ahead of schedule, so we can take it here unless there's additional questions.
Okay, thank you.
Thank you.
Excellent presentations. Thank you, Ravi. Thank you, Denise. So we're gonna break for lunch. So right now we're gonna come back at 1:30. Thank you everybody for your attention and all the speakers for this morning for all your talks. Excellent. Thank you. Okay, welcome back everyone. We will continue our conversation on these advances, so on how we advance data and metadata standards. Our next session is going to talk about the use of other applications, and it's going to be chaired by Dr. Matt McAuliffe. Dr. Matt McAuliffe is the Chief of Scientific Application Services and the section chief is the Chief of the Scientific Application Services section of the Office of Scientific Computing Services at the Center for Information Technology at NIH, and he oversees the Biomedical Research Informatics Computing System, BRICS, which is a comprehensive data informatics system designed to effectively or efficiently collect and validate and harmonize and analyze research data sets. He also provides computational and engineering expertise to various clinical and biomedical informatics activities at NIH, and is dedicated to supporting data sharing and biomedical informatics and making data fair, findable, accessible, and interoperable and reusable across multiple NIH efforts. I will let him introduce the session. Matt?
All right, good afternoon. Okay, I'm going to go ahead and share. I'm going to have a few slides to show here. Give me just one moment. There we go. Okay, are you able to see my slides now?
Yes, just go ahead and swap the display up in display settings.
Oh, okay. I had gotten that right. Okay, display settings. Yep, just a moment.
And then swap. Yep.
All right.
There you go.
Great. Good afternoon. So I am going to talk a little bit about how, building a team effort to build and support research projects and the importance of that, because, I think that you've all seen in these various projects how involved they are with not only the clinicians, but biostatisticians, but also the technical area. building repositories, building the informatics structure to support and accelerate the research. So we're going to have 4 different talks. I'll be really pretty brief with mine, and then we'll give you 3 different points of views with a clinician, and then a biomedical engineer, and then a data scientist. So moving on from there, let's see what we got here. So I'm responsible for building the BRICS, which is the BRICS platform, which is the Biomedical Research Informatics computing system. And I've had to work, so my background, I have a PhD in biomedical engineering. And so I've really tried to position myself as that person in the middle that can help translate the stakeholders or the researchers' needs and implement that kind of functionality and add value to that, and then work with the developers to implement that kind of functionality. So again, we're working, as building a team. And in fact, what I've done is built an infrastructure that is generic and supports a lot of different workflows that researchers need. But I can deploy this in a number of different ways, both on-prem or in the cloud, to support all different kinds of imaging data. So we heard earlier the importance of linking data together. And so now we deploy this instances of BRICS, and one of them is support traumatic brain injury, and others to support Parkinson's disease biomarker effort, and so on. So I think we all know standards are important, but it's also important to understand that standards come at different levels. You have at the data level, data standards, you have common data elements, you have data models like OMOP and FHIR. You also have different file formats, like in imaging, you have DICOM, which is a pretty standard way, but a kind of sometimes can be cumbersome way. NIfTI is another file format. There's also standards for exchanging data. I think as you can see, as NIH moves towards this federated asset program, standards will play a fundamental role in the designs of these data sources so that they can be integrated efficiently. Whoops. Let's go back one. There we go. So it's kind of starting from the top. In my drive to build this system, I was involved in early efforts to define how data in repositories can be shared, and the importance of sharing data and understanding those very high level requirements, or loosely standards, and have been part of making data fair, findable, accessible, interoperable, and usable. And now when you move that one level deeper, you see that we have persistent identifiers, which can be kind of a standard. You have DOIs, or digital object identifiers. You have standard communication protocol, which I touched on earlier. You have vocabularies and common data elements and other community standards. So you can see at every level of being able to share data and make it available, it's important to address standards. So I'm going to just give you one quick example. Common data elements. I'm using common data elements, I think, a little bit differently than others. When I mean common data element, I mean everyone's using that exact common data element, and they're using the permissible values in all the same way, so that, in fact, so this kind of illustrates the point that I'm trying to make, is that when people collect the data, and this is mostly for prospective studies, and like for our FITBR or traumatic brain injury, data is always collected consistently up front. And you can see this example here. If everyone collects very unstructured data, or even if they collect structured data, but they collect the same kind of concepts in different ways, it makes it very difficult to then harmonize that data on the back end. You have to come up with either some semi-automated ways of combining that data, or to just slog through it. And it's kind of been shown that it's an immense amount of resources to do that and to redo that often. So our idea, and I think it's been used by many people, but we're really a strong proponent, and our systems support that, is that we collect the data all consistently up front. And it's a little bit difficult to take retrospective data, although it can be done, and remap it into those common data submissions. That can be done, but that's also a big effort. But what we do is, when the grantee gets that grant and they're required to submit the data into that particular repository, we work with them to understand that they're all collecting the data the same way. That data then gets validated and goes into what I call the informatics system. In our case, it's Bricks. And then you can query that data very quickly across studies and aggregate that data within seconds as opposed to, say, months. We also use other standards in defining our data elements to help the understanding of that data and to make it more AI ready. We use UMLS, and we built tools around the UMLS tools from NLM. And we assign CUIs, or concept unique IDs, to our data elements as well as permissive values to make that data more consistent and AI ready, as well as being able to aggregate with other data that maybe wasn't collected with the exact common data elements. Okay, so we've built some other tools too. This is a nice tool. You'll be hearing from Maria Bagonis a little bit later. She helped us build a tool that works on retrospective data and mapping it to our common data elements. So her first effort in this was to map retrospective data elements to our common data elements. And that was the first step in building a tool, which we're now integrating some of her work into this semi-automated tool that allows us to take retrospective data, try to pair it using an AI tool to map it to common data elements, and where it couldn't really do a good job, or if you decided that it didn't do a good job, you could manually pair those data elements to get the exact mapping that you wanted to. So again, this involved curators, data curators, clinicians, data scientists, and developers all working together to build this one tool to really meet the needs of this particular part of the research effort. This just shows you the example within our tool where I actually queried across 17 studies and aggregated the data for the Glasgow outcome score, which is a measure of how bad a particular TBI was. And because we collected that data, going back to that other slide, we collected that data all up front and validated that data up front. We could query across those 17 studies and pretty much instantaneously aggregate that data. And then you can filter that data to find a specific cohort that you're interested in. So I think if you have a good, strong team and have the ability to implement the kind of workflows that you need, having a team from a consistent team of people with the various kind of expertise, it's really, really going to make the science better, make it more effective and more efficient. And I did want to point out one group here that I didn't call out before is user interface. And I'm an engineer, and sometimes I would build or work with the developers to help build a very kind of engineer-oriented, but we've taken that step back now, and we've really worked on the UA, UX, the user interface, to really improve the usability of the system. And I think that's really, with a lot of input from the stakeholders, the scientists, to make it a better system for the users. Okay. And then has been a UNC grad, I had to throw in a quote that I think is very applicable here. But I think we all want to kind of win championships or do really great science. And so that's what that's all about. And so now I am going to introduce Dr. Ron Summers. So I've worked, in fact, one of my first collaborations here at NIH was with Dr. Ron Summers, and it's been a great collaboration over the years working with him. And oops, sorry. And so Dr. Ron Summers is a tenured senior investigator and staff radiologist in the Radiology and Imaging Science Department at the NIH Clinical Center here in Bethesda, Maryland. He leads the Imaging, Biomarkers, and Computer-Aided Design Diagnosis Lab. He is a fellow of the Society of Abdominal Radiologists, the American Institute for Medical and Biological Engineering, and SPIE. His awards include the Presidential Early Career Award for Science and Engineers, the NIH Directors Award, and the NIH Ruth Kirstein Mentoring Award. He is a member of editorial boards of Academic Radiology in the Journal of Medical Imaging, and a past member of the editorial boards of the Radiology and Radiology for Artificial Intelligence. He has co-authored over 700 journal, review, book chapter, and conference proceeding articles, and is a co-inventor of 17 patents. His research interests include thoracic and abdominal imaging, large radiology image databases, and artificial intelligence. And with that, I'll hand it off to you, Ron.
So it's a great pleasure to be here today. Thank you so much for the invitation to speak. And all right.
Just say next slide whenever you're ready.
Next slide, please. Okay, these are my disclosures and disclaimer. Next slide. So I'm a senior investigator in the NIH Clinical Center, and I'm going to be speaking from the perspective of a lab PI that manages a small lab. My lab focuses on imaging phenotyping, which is the assessment of expressed traits as influenced by genetics and the environment. And because of radiology image complexity, it's been a missing ingredient. And one of my lab's major contributions to medicine is to enable the use of image phenotyping using radiology images, which provides the capability to assess treatment response, data mining of unstructured imaging data, and integration with non-imaging data. Next slide. So I thought I'd start by showing examples of two projects from my lab's research that are relevant to the NIDDK mission. This is the first of the two, which shows the use of body composition analysis using AI of CT scans to assess patients on the GLP-1 receptor agonists like semaglutide. And this, the image on the screen shows a CT scan of the abdomen of a patient before and after treatment with one of these drugs. And if you focus on the yellow part of the image, that's the visceral fat. And you can see the large decrease in the amount of visceral fat shown in yellow, comparing the pre-treatment and the post-treatment images. And this is work led by Perry Pickhardt, one of my collaborators, who's from the University of Wisconsin-Madison. Next slide. This is another example of a project that uses AI to assess abdominal CT, in this case, diabetes. What you see on the left is a zoomed in image of a CT scan of a patient, of the pancreas of a patient without diabetes. The pancreas is this upside down U-shaped structure. It's homogeneous in density, and the borders of the pancreas are very smooth. And if you compare that to the pancreas of a patient with diabetes, you can see the pancreas's margin is very lobulated, and there are inclusions of fat in the pancreas. And what we found was that changes in the pancreas on CT scans that occurred as early as 7 years prior to diagnosis of diabetes could be detected on scan. So very relevant to the NIDDK mission, and we're performing some follow-on projects in other conditions that as part of an NIDDK multi-institutional trial. Next slide. So I'd just like to give an example scenario where we ran into a problem with data standards. So we were working on this multi-institutional trial of patients with acute and chronic pancreatitis, and we had a lot of CT scans, but found that they varied considerably from one institution to another. For example, the slice thicknesses, the reconstruction kernels, and the anatomic coverage were very variable. And that required a substantial effort in harmonizing the imaging data to use it to develop an AI system. Next slide. Another issue that we run into very frequently as a single lab is data scarcity. It's been said by others that data are the new oil in the AI era, and AI model development requires large data sets from different populations. But unfortunately, well-labeled data, while helpful, can be very expensive to produce. For example, imagine a scenario where you have 100,000 CT scans. It's clearly going to be very expensive to label that data set properly, and you need expertise to do the labeling. Next slide. Okay, as early as 2003, I and my colleague Mike Vanier argued that we in radiology should be sharing images more, and certainly today, things have changed dramatically. There are many more shared images available on the internet, but these shared images have a number of issues that make it hard for labs, individual labs, to do AI research. Next slide. Some of the problems we've run into are some differences in these data archives. For example, we have different data formats for different archives. There are many different archives, each with a wide variety of computer interfaces. These archives have varying user agreements that range from permissive to very restrictive, and metadata varies widely, and the costs also vary widely. Costs are mostly relevant for those who wish to upload images to archives like an individual lab. Usually these public archives are free. Next slide. They're free for the user that wishes to use the images. Another issue, as Matt alluded to, is image formats. Clinical images are voluminous in individual size and numbers, and the DICOM standard, which is the standard for radiology and other biomedical images, is frequently advocated, but it's relatively storage inefficient because each slice in the imaging volume is stored in a separate individual file. And you can imagine having to transfer thousands to millions of images, and that turns out to be difficult, particularly over networks. We tend to use the NIfTY format developed for neuroimaging. It's quite storage efficient, but one downside is that the metadata can be reduced or lost. Next slide. The other thing that we've been doing more and more, particularly with large language models, is working with clinical text and different metadata, where text anonymization is very important, but is challenging to do well, and manual review is often required. And here we run into the same issue that if you have tens of thousands or hundreds of thousands of clinical text reports, manual review is intractable. When we share clinical text, we frequently use the comma separated value format. Also, Excel is widely used. But there are many other ways of sharing text data. Next slide, please. So just a few thoughts about what is needed going forward. As Matt indicated, data harmonization is critical for biomedical images and metadata, and clearly collecting the data consistently is extremely important, particularly on multi-institutional trials. I think it would be helpful to either consolidate image archives or come up with a central archive that is funded in such a way that more people can upload and access the information, preferably with more permissive licenses. Standardized infrastructure is also critical, particularly for smaller labs that don't have people like data engineers and other support staff that might be available for larger clinical trials. And I think we need to have more discussion at NIH and elsewhere to make more clinical data publicly available, particularly all the data that's currently paid for by the government, for example, through Medicaid and Medicare. This is something that, of course, would need patient and congressional buy-in, but I think it's really important that given the amount of taxpayer money spent for healthcare in this country, that some thought to be given to use that data in a privacy-preserving way to improve clinical care. Next slide, please. A couple words about AI model sharing. Currently, the minority of AI publications share the AI model. Usually, the code is shared, but this is of limited utility without the AI model. So that's something that's been lacking that I think needs to change. Next slide. Regarding clinical text, again, the corpuses of clinical text are fairly limited, particularly in the radiology space. And because these corpuses are so limited, most published research today uses the same clinical text corpuses. So given the availability of LLMs and other types of generative AI, we need more clinical text. And one way to do that would be to have better standards for clinical text anonymization. So I'm hopeful that that can happen in the near future. Next slide. Before I conclude my remarks, I'd like to mention two projects from my lab that leveraged publicly available data to make advances in radiology AI. This is the first from Pritam Mukherjee, who's a staff scientist in my lab. He's an associate scientist. And he wrote in this article in Radiology a couple of years ago how to use privacy-preserving large language models for labeling radiology reports. And this study used publicly available data in order to develop this system. Next slide, please. This is a project from Yan Zhuang, a former postdoctoral fellow in my lab, who is now an early stage scientist at Mount Sinai Medical School in Manhattan. He developed an AI system that can segment 62 different anatomic structures in the abdomen on abdominal MRI, including the major organs, the bowel, the major vasculature, and the bones. And he validated this system on two external data sets called AMOS, and the second was the Duke liver data set. Again, a project that leveraged public data to make advances in AI. Next slide. So to summarize, we know AI has transformed biomedical image analysis and informatics, but clinical images and text, at least in the radiology area, remains scarce. I think these data archives must balance the complexity of the data with generalizability, simplicity, and cost savings. And simplicity really and standardization are really desirable, particularly for small labs that have limited resources. Additionally, making clinical data publicly available and AI ready, in my view, has the potential to really improve patient health. Next slide. Next slide, please. I'd like to thank the members of my lab that put together the research for the projects that I've shown, and I look forward to the panel discussion.
Thank you, Ron. That was a great talk. I definitely feel the importance of data sharing and how effective that can be. The next speaker here is Dr. Dominic Nathan. He is a bioinformatics director for the Military Traumatic Brain Injury Initiative, where he leads an interagency collaborations on developing informatics tools for research and clinical trials in the area of data collection, AI, ML, analytics, and proteomic analysis pipelines. Dr. Nathan is also an adjunct professor at the Uniformed Services University of the Health Sciences, where he mentors doctoral and medical students. And with that, I'm going to hand it off to you, Dominic.
Thank you, Matt. I'm going to share my screen. Can everyone see my screen?
Yes.
All right, thank you. So I'm going to talk about the biomedical engineering approach, and sometimes this is a little bit overlooked. Full disclaimer, if I say anything wrong, blame me, don't blame the government. And also, I may be talking about certain products that by no means is an endorsement of any single product. What is the current clinical trials landscape within the NIH? There is a heavy emphasis on practical applications for direct care and translation into the clinic. Clinical trials have a very, very diverse and rich set of data. A lot of these data sets are disparate. The data set is growing, and there are large amounts of data. And correspondingly, there is an increased burden for management of these studies, supporting these studies, and then associated regulatory resources that are needed. And all of these come down to financial cost. As all the speakers mentioned, there's an increased use of AI and multimodal analytics, and this is also very, very data hungry. And unfortunately, right now, it is very common to see multiple siloed systems. These systems are either localized to certain labs, certain centers, or just within an institute. And there was an extensive review that was conducted by the Office of the Director, and they found that there are, more than 100 different systems that are in use. The other issue is across the NIH, there are disparate and unequal resources. So you might have some groups, centers, or ICs with lots of funding, and they're able to get different capabilities. And then you have some with very limited funding, or you have a smaller IC and there's very restricted in what they have access to. Unfortunately, there isn't a uniform solution across the NIH at this moment. Also, the other problem is data collection practices are very, very variable, and curation is often not fully emphasized. What this leads to is limited return on research investments, because as we try to do AI, multimodal analysis, or even just trying to look at data across a longitudinal timeline, we're not able to fully grasp what is there in an efficient manner due to these inherent variabilities. And a lot of times, we have labs that have been collecting data for years, and the return is often low because it's difficult to harmonize the data. These are kind of things that have been published. So a lot of researchers have failed to reproduce research findings, and then 50% apparently have not reproduced their own findings. So reproducibility is an issue. And I know Ronald Coase had talked about torturing the data. I don't believe in doing that. But a very good point that Baron Mons has brought up is it's not just so much collecting, but how do you manage and how do you curate, and then how do you make that available? So the NIH is actually leading the way in this regard, and there have been a couple of policies that have come up about data sharing, data practices, data management. So what really needs to happen? There are two broad levels of change that needs to happen. The first is, let's rethink the protocol design. And when we start a research study, we have to look at an emphasis of data curation, because the lifespan of data isn't just within the confines of a study. Now, data is increasingly living way past, and it's being reused for other things that the original study didn't intend. So during the planning phase, what do we need? We need a data management plan, a data dictionary, and then we have to look at maximizing electronic data collection. And some of the resources we could look at are, regulatory management tools, data access plan tools, because as we manage multiple studies across various ICs, the documents that we generate tend to grow in size and also complexity. As we look at execution, we do need standardized QA/QC processes, data query, data access control. And then again, we have to maximize electronic data management practices as we're running our studies. And what this looks like from a technological perspective is having an integrated data flow within the system that we're using. We want to have audit trails and also electronic logs. So rather than doing a lot of things on pen and paper or even like emailing documents, we want to have a central location where a lot of these things can be managed from a more efficient perspective. And lastly, after the study closes out, we do need the ability to query the data and also look at how are we going to share those things. And what we need in tandem are DOIs, access control, and then tracking of publications, because that is an important benchmark to see if the repository and the work has any benefit or if it's of value. The second aspect of what needs to change is really understanding the requirements. What do we need to support clinical trials and human subjects research? There's a lot of emphasis on electronic data capture, but that's only one small piece. The other items that are important are such as regulatory compliance. So auditing the data, making reports, adverse event generation, making sure that the documents that pertain to a study during its lifespan, the reviews, any compliances needed, such as licenses, trainings, those are all maintained properly. And then we also need proper data management processes that are inbuilt. In terms of team access, we have to be able to track who's accessing what data, what is the person doing. And then if we're doing a clinical trial, we want the ability to integrate with the pharmacy so that if we're testing a new drug or new device, the pharmacist can help administer those items. In addition to this, we're also managing subjects. So the big thing is being able to schedule a subject. If you're doing a randomized control trial, you want to be able to blind, unblind, collect informed consent from the subjects, things like that. And very importantly, what often gets overlooked is the infrastructure. So all the technological tools have to live somewhere. So things such as servers, network, how you're going to host the data, what kind of data you're collecting, you have to have the necessary IT compliances in place. And then the last two pieces are analytics and being able to feed into AI ML tools. A lot of them now on the cloud. You have the three top clouds. You have Microsoft, Amazon, and Google, depending on what your flavor of choice and tool of choice is. Being able to extract data from databases, and then being able to manage the clinical trials. So having an inbuilt clinical trials management system. So these are the high level requirements. And what are the two options? A lot of times people tend to look at commercial systems. Commercial systems offer several key advantages. One, they are very quick. You can get a lot of out of the box solutions. Many of the commercial systems are mature and there's a relative quick turnaround time for setup. Customer support is also available and there are many diverse resources. The disadvantage of a commercial system is there's very high cost with products, services, and enhancements. A lot of commercial vendors now are moving towards a software as a service or platform as a service. And that doesn't really lend itself very well to scaling. So if you have 10 studies or if you have 100 studies, the price actually grows exponentially. The other item is also there are limitations with regulatory compliance. So if you bring a commercial system in, you have to make sure that the platform meets the NIH's security and safety requirements. And also, as I mentioned, when you start going to a software as a service or platform as a service, a lot of times the vendors would want your data on their platform. And this, creates a lot of issues with who owns the data and control, because as research dollars ebbs and flows, then you may lose access to your infrastructure and your capability. The other option is a low cost of free system. The advantage is, you're not paying a lot for it and you have direct access. A lot of the low cost systems have flexibilities inbuilt. You can, build any system, any collection, any format you want to. But the downside to that is support services are not necessarily available easily. And it is on the institution to implement and bring the system into full compliance, which can actually get very, very expensive. A lot of times there are duplication of efforts, especially if you get a free EDC and you have to bring it into your IC and get it up to standards. That, again, a lot of people have done that. It's kind of redundant. And then there are also problems with data harmonization, because the balance between flexibility and having a standardized way of collecting and curating data oftentimes is overlooked. And this causes problems with data quality and control. In addition to that, there is a high risk of security and compliance, because oftentimes commercial systems or the free systems cannot do every single thing for a clinical trial. You end up having to get several of these. And then you also have issues with data harmonization, because now you have to get these multiple systems to talk to one another. A lot of them have different formatting, and trying to get them to merge the data is quite tedious. And as I mentioned before, with the move to software as a service and platform as a service, there are concerns about data loss and essentially knowledge retention. So really what we want is a central government solution across the NIH that can give us all our features and capabilities, but then it has low burden, financial, administrative, and support burden that's low. And what that looks like is, if we look at individual siloed systems, a lot of these create an increased security and risk, because now you have to get the systems to talk to one another. You have to get each one of them would come with a license, and the cost, if you can imagine, would increase significantly. There are some applications that offer one or two things, such as you might have a data collection platform with a clinical trials platform, or you might have a repository that you can also use as a biorepository. But again, managing the licenses, and a lot of the vendors do not get into fixed price contracts, because oftentimes the licensing fees will increase over time, and that's difficult to predict. Um, Also, the hosting and the storage and moving to platform and software as a service, a lot of the vendors wouldn't want you to use their infrastructure, which may or may not be in compliance with government requirements. So really what this poses is challenges with licensing fees. And I've seen this across the NIH, I've seen this across the DoD, where the fee might be a certain amount, and people would sign an agreement for 5 or 10 years, and then in year 3, 5, or 6, the licensing fee suddenly jumps. User experience, again, having to integrate multiple systems together sometimes is difficult. A lot of these systems do one thing, and they do one thing somewhat well. However, a lot of them also have limitations. And what we hear a lot from our users are it's difficult getting into 2 or 3 systems. If I need to pull a report, I have to merge my data, and just to get something simple, it's very challenging. Also, for our poor tech support individuals, because the software has to live somewhere, and they are now having to support multiple servers and underlying networks and infrastructure needed. There's also implementation, so we have to make sure things are in compliance, and again, having multiple systems creates an increased burden to do that. The most important thing really is sustainability, because a lot of times it is difficult to look into how does this landscape look like in 3, 5, or maybe even 10 years. What are the things that we can control? Because the biggest unspoken gorilla in the room, if you will, is funding. Now, in this atmosphere of limited funding, what will guarantee that I have sustainability of operations in my out years? So I may have money now, but how do I guarantee that I'm not going to have data loss or a compliance issue in 3, 5, or even 6 or 7 years from now? And then security is also very important. We do want to know where our data is, and if it is outside, do we have access to that, even if funding ends or changes? And lastly is data. Data is big. So data management practices, data access processes, all of these items, we want it integrated. And really, a lot of these items, we want to solve it by having a government solution, because it alleviates things such as licensing fees and gives you more control to dictate how can the tool be customized for our needs across the NIH, and also provide a sustainable option. And this is how BRICS essentially came about, because BRICS offers a uniform set of tools. Everybody, you can get the same platform. These are some of the modules in BRICS. There's a uniform architecture, uniform set of servers. And the best thing about it is the security and compliance actually carries across the different ICs. So it really provides efficiencies in that regard. Again, these are some of the tools we have inbuilt into it. It's a pretty robust platform. It's instead of having multiple siloed systems, now you have one platform. We have multiple.
I'm just gonna have to ask, give you about a minute.
Sure. Multiple data collection methods, including our offline collection with mobile devices. And really, just in summary, a lot of the pain points that we have gathered over the last couple of years, we have kind of really built up on those, and this is what the BRICS platform offers. So no licensing fees, single set of hardware, and it doesn't matter if you're a big IC, small IC, limited resources. The single set of hardware really helps in terms of cost and maintenance, meets all the main system requirements that you need. And then it provides a comprehensive set of tools. So everybody gets the same resources and they get the same equity in being able to do their research. And lastly, the data is stored at the NIH or on a government hosted infrastructure. So there is continuity of operations and the fears of data loss are reduced. With that, are there any questions?
So we're going to have questions at the end, Dominic, but thanks. That was a great talk. You can tell that we as biomedical engineers think about things a little bit differently. So it's not only about reuse of data, but reuse of infrastructure and other kinds of workflows that we can help with the process to streamline the research. Next, I would like to introduce Maria Bagones. Dr. Bagones joined NIH as a Data and Technology Advancement National Service Scholar. We call them Data Scholars. She started in the fall of 2023, where she is currently working to develop innovative AI query tools to facilitate the use of biomedical research informatics computing repositories. Before working at NIH, she managed several multimodal neuroimaging studies of early childhood brain development as a T32 postdoctoral NIH fellow in biostatistics, also in mental health neuroimaging and genomics at the University of North Carolina. She then worked at the NIH SBIR funded startup space, developing a clinical decision support tool for the early detection of autism. She holds a PhD in biological and biomedical sciences from Harvard University and an MS or a master's in theoretical chemistry from the University of Oxford. So it's all yours, Maria.
Excellent. Can you see my screen and can you hear me? That'll
Looks
be my
great.
first.
Yep.
Excellent. Yeah, so it's really been exciting to be on this esteemed panel. I'm really honored. As I said, I'll be looking more at this at a data scientist perspective going forward. So I thought the best way to start was to actually just share a personal research story, how I actually ended up as a data scholar. So but I'm in the current position I'm in because after my postdoc, I was actually working at an SBIR-funded startup, as Matt mentioned, developing a clinical support tool for early detection of autism. And what it became really clear is there's a major and huge discrepancy between the type of models that you would have for a Nature paper versus what you're going to go a clinical predictive model. I mean, we all know this in theory, but I think we don't realize that the magnitude of that gap until we've actually been in the space. And I'll just say, reproducing and extending models really requires knowing quite a lot, actually, really good data standards, sampling distributions of the cohort, processing pipeline, model architecture. A lot of these are not collected, or I mean, it's getting better, but like particularly for some of the work that we were doing, I mean, these are good scientists, but it was quite difficult to get any of those to be able to extend the work, right? And then ultimately, it also requires lots of high quality data. That's the other nail in the coffin that everybody's been chatting about, right? So ultimately, we didn't have enough data. I mean, we're pretty sure there was signal there. We made some really good strides, but so that's how I started working more with the NIH. I was mainly looking with NDA, trying to search actually for extra data that could be used to go into our models. And we had to look for a very specific cohort. And I was actually quite surprised in that. So we've made a lot of progress, right? Having these different data repositories, we made a huge project. We talked about bricks, and then NIMH NDA has a similar format, and getting the data in. But being able to actually query the data quickly once the data gets large is a non-trivial task, actually. And I was surprised. It was very, very, very difficult to quickly even understand if there was that data of the cohort I needed. I was scripting stuff, and you had to download a whole bunch of data. So that's why I actually came here as a data scholar, because I ended up being able to work on with Matt McCullough and the Bricks repository and addressing some of those challenges moving forward, right? So most people, the one common answer is just like, okay, well, we'll standardize everything, right? We'll have these common data elements, and they make a huge, huge, huge difference in being how fast you're able to actually aggregate data. But it's a little bit tricky as I've been working with these. So what I consider a good CDE, it enables the researcher to quickly and systematically unify a data set, right? That can be combined or compared. It's a very, we just need that information. So this gets a little bit logistically challenging because you need, as I think Denise was saying, this balance, right, of structure and flexibility. So we need to be standardized enough to facilitate data aggregation and eliminate all those crazy unintentional divergences that are just haphazard noise, right, that decisions that clinicians make or people make with their studies. But we also want to be able to maintain, we don't want to lose information, right? We want it to be able to evolve. We want it to be a living language. We want it to move forward and maintain important scientific differences. And so fortunately, the AI large language model, as Ravi was saying quite much, is actually really, really helpful in this regard because we get a little bit more bandwidth. So these text embedding models and generative large language models are really good at synthesizing detailed, nuanced text. And so we have a couple, I'll just briefly say about the AI projects we have at Bricks. One is the cross-mapping tool, a CDE cross-mapping tool. To map new measurement variables to the common data elements that we are in the Bricks data element dictionary. The approach is really, really similar to what Ravi was talking about. It's really funny, actually. We were on the chat, the host panel chat, and Melissa was also like, yeah, we're using that approach too. So it's really great to have these type of forums to all come together and, be able to collaborate, right? And then we're also expanding it to a dataset query tool, to be able to automatically identify and aggregate relevant cohorts specific to studies that can be combined to answer a specific question. And again, this is going to help facilitate predictive machine learning models and maximize the data reuse. So with that, so as I said, with the CDE toolkit, we need to try to reduce the unintentional redundancy. Here, I think Denise talked a little bit about, this is, if we talk about traditional to newer technology, we are using both, right, approaches. The UMLS concepts are, you can manually assign those to the data elements. They've been curated officially. That was kind of developed a little bit before the large language model explosion. And then you can also look at it in vector embedding space, as just like Ravi was saying, you can look at this text as a numeric vector, and things that are close together things that have similar meaning will actually be close together in that space. And here's just to show really that this is, they're really two sides of the same coin. Here's just our FitBIRD data dictionary in vector space, actually a very simple model, not even probably like the state of the art at this point. And you can see right now that naturally, given the model, you're going to cluster by concept. And so just to reiterate, these concepts were manually vetted by a human, right? But like the model didn't know anything about that at the time, right? So given Ravi, it's very similar to Ravi's approach, and that clustering can be really powerful. And then we have this aims for DE is just basically putting that into a cross-mapping tool. We do have an initial version that's online. A new version is going to come really soon. Hopefully that will have all the Bricks data elements in it. Again, Matt said it was retrospective, but it's actually helpful for planning prospectively as well, just because it's actually, as these data element dictionaries get larger, it just becomes really hard to find what you need when you're planning the study. I'm running out of time. Okay, so we also, as Matt was saying, we have a form structure, which is a collection, actually common data elements. We ask our users to use common data elements, but we also group them by form structure. And when we do that, it does make it really easy to begin to pull a larger data set. So for this is the GCS data set. This is the GCS form structure. I can easily pull data over 11 studies, and you can see that it begins to reveal like once you actually look at the data set, there's quite a bit of heterogeneity in this data set. Here is just like the example that I show. Oh goodness. Okay. Yeah. So I'll try to go a little bit quicker because I know we didn't get to the end. But I'm saying like it's a little bit difficult to identify the combinations or forms of interest. It's time consuming. And it's hard to check the sampling distributions without downloading. So that's why we've been working on this AI tool, which uses the study and form information. Yeah, and then so I guess since we only have 5 minutes left, I will I have a lot of things that could be done in a technical and in governance. But I think, most exciting thing I think is moving towards an interactive personal assistant to help researchers plan their next study. I think might be basically it would be combining a number of the smaller tools that we are currently using and putting those out together in a package that would hopefully help people find what they need faster and encourage them to use common data elements. And so with that, I think I will stop.
Thank you, Maria. That was awesome. That was I'll ask the other presenters to join in. I apologize. I think I took too much time on my preliminary presentation, so I apologize. But excellent presentation. I think we have a few minutes though for questions, and I think we have one online. And I'm going to read it. It's from Benjamin Howe. A problem of introducing new and more efficient standards is that there's so much data using the old format. This requires an immense amount of compute power to update them. What is a good possible solution for institutions to address this that does not have such compute resources? And I'm going to hand that one off to Ron because I think he has some experience with this.
Well, Benjamin was a former postdoctoral fellow in my lab, so I sort of know where he's coming from. It's certainly not easy dealing with large data sets with variable formats, particularly data sets that are improperly formatted or don't include enough metadata in order to do your project. So sometimes you're stuck and you have to communicate with the original investigators to get the information that's needed to address the issue. But it's an ongoing challenge. But without standards, you're going to have this problem will keep repeating itself ad infinitum because there's always the idea that the next data format is the best ever, and so we have to use that one. So you're in a constant treadmill of new new formats and new standards. But I'm a firm believer in simplicity, and any approach that is inherently simple will be preferable, particularly to individual labs like mine.
Did anyone else want to jump in on that? Yeah, I think you're exactly right, Ron. I think you got to pick your battles too. Find the biggest problem with the simplest solution and try to attack that. I think we have maybe time for one more question, and I'm going to address this to you, Maria. How can we best integrate the many areas of expertise, clinical, regulatory, engineering, and data scientists, to generate robust data standards that increase our efficiency in making data more fair?
Yeah, right now it's there's a bit of a revolution in governance too. In what was there was many silos previously, right? In being able to, sorry, excuse me. There was previously a lot of silos in clinical AI based. We didn't even really know that we needed AI based technology, right? And so it's, I'm sorry, excuse me.
You okay? Or do you want
Yeah, I'm okay. If someone else wants to jump in, they can. Thank you.
Dominic, is there anything really quickly you want to add to that?
I think so. We have a lot of tools right now, and if we can leverage AI, there are some opportunities for efficiencies that can be gained from that. It's just, how do you set it up and how do you use it? And we do have some partners across like Microsoft and Google that are looking at problems like this and are actually extensively working on solutions across the federal government. Over.
Great. So I am going to wrap it up. We're just about at time here. So I want to thank all the panelists for great presentations. And I think in summary, this is kind of apple pie and motherhood, but really teamwork is really important, and getting everyone involved early on in the project so that they can help provide their piece of the puzzle to advance the science. So again, thank you everybody, and we'll hand it off.
Thank you.
Thank you, everyone. Excellent presentations. We're going now to transition the conversation from the various approaches to building partnerships and facilitating the establishment and adoption of standards we have been talking about. And this session chairs are Ms. Amber Reed and Syed Hakim. Ms. Amber Reed serves as the Assistant Director of the Office of Data Science and Health Informatics within the National Eye Institute. In her role, she spearheads initiatives aimed at enhancing data collection, sharing, and interoperability. Her overarching objectives are to advance public health by leveraging scientific data and effective knowledge management strategies within the field of eye health sciences. Mr. Syed Hakim is a data scientist at the National Eye Institute and within the Office of Data Science and Health Informatics. In this capacity, he is responsible for implementing data standards and data science principles to make any eye data fair. And that again is findable, accessible, interoperable, and reusable. His interests include promoting tools and data management and sharing data mining, analyzing ocular images, and creating data visualization. I'll pass it on to you both. Thank you.
Perfect. So to get started, hello everyone, good afternoon. My name is Amber Reed, and I'm the Assistant Director in the Office of Data Science and Health Informatics at NEI, the National Eye Institute. So I am very excited to be here with you today to talk about how partnerships and specifically the role of government agencies can help advance data standards in healthcare. I'll focus on one particular success story that we've had recently in the ocular imaging space that really highlights how thoughtful collaboration and shared goals can create meaningful impact. Next slide. Yep. Thanks so much. All right, so let's start off with the need for ocular imaging standards. So ocular imaging is really foundational to both clinical and research in eye disease. It also holds huge potential for artificial intelligence and data science. But we continue to face persistent challenges with image exchange and data retrieval. One of the biggest issues we have is with proprietary formats. Devices really don't talk to each other easily. And because of that, clinics have to manage multiple image systems. And even on the research side, we've had informatics PhD students who couldn't really get access to basic imaging data like optical coherence tomography or visual fields. And despite 20 years of efforts, most notably through DICOM standards, we've seen almost no meaningful impact in ophthalmology. So in May 2022, NEI actually co-led an imaging standards workshop with ONC, which is now ASTP, and the FDA to really better understand barriers to interoperability. That was then followed by a public statement from the American Academy of Ophthalmology, or AAO, and the Association of Research in Vision and Ophthalmology, which is ARVO, later that year, declaring the time is now for standards in ocular imaging. It was really clear that there was community alignment on this. Next slide. So that workshop catalyzed a coordinated position across all of these agencies. Each partner really brought forward unique tools, and we published a position statement that served as a roadmap to interoperable ophthalmic imaging standards in the United States. So FDA formally recognized DICOM as a standard for ocular imaging. This was huge. This allows vendors to label their products as DICOM compliant, which is subject to FDA auditing. ASTP, or formerly ONC, added DICOM to their interoperability standards advisory and has submitted relevant data elements for inclusion in the US CDI. They're also considering adoption criteria that would require EHRs to provide access to medical images. And then at NEI, we've committed to integrating standards into our funding strategy. So all notices of funding opportunity now encourage applicants to address standards conformance when imaging is involved. We also launched an open access GitHub repository for sharing DICOM-based coding tools. So all in all, this wasn't just policy to us. I hope it's clear that this was a shared strategy to drive practical real-world change. Next slide. So lastly, what really made this partnership work? There are a few key factors here. One, we defined the problem and desired outcomes clearly from the beginning. Two, we leveraged each agency's unique strengths, so we combined scientific, regulatory, and technical perspectives. We involved vendors and researchers early, and this really built trust and buy-in early on. We kept, excuse me, we kept communication flowing through regular updates and transparency in our decision-making. And ultimately, we stayed flexible, so adapting strategies as new challenges emerged for us. Ultimately, this partnership demonstrated that government agencies can play a meaningful role, not just in funding or regulation, but as conveners and facilitators of progress. So while this example comes from ophthalmology, I think the principles are broadly applicable here. One, define the problem. Then share ownership. Use your levers strategically. I cannot, go over that enough. And then last, don't be afraid to experiment. I just want to take this opportunity to say thanks and to, for the opportunity to share the success story with you all. And I'll now turn it over to my colleague, Syed Hakwani, who will moderate a great panel that we put together to discuss partnerships and the role of government agencies as facilitators. Thank you all.
Thanks, Amber. First of all, I would like to thank the presenters, panelists, organizers, and attendees for the great workshop and discussion we had in these past 2 days. In this part of the session, we are going to discuss the role of government agencies in building and facilitating the establishment and adoption of data and metadata standards. I would like to start off by introducing the three panelists. Dr. Michael Chang is the director of National Eye Institute. He is board certified in ophthalmology and clinical informatics, and his research focuses on retinopathy of prematurity, telehealth, artificial intelligence, electronic health records, data science, and genotype-phenotype correlation. Dr. Chang began at NIH in November 2020. He serves as a chair of multiple NIH-wide committees and working groups involving data science, imaging, health disparities, and clinical research. He is member of the NIH FDA Joint Leadership Council and a member of the Health Information Technology Committee of the U.S. Assistant Secretary for Technology Policy. He is an investigator at the National Library of Medicine, and his group has published over 300 peer-reviewed papers and developed an assistive artificial intelligence systems for ROP that received a breakthrough status from US FDA. He's also an elected member of National Academy of Medicine. Next, we have Dr. Michelle Tarver. Dr. Michelle Tarver is a visionary public health executive, board certified in ophthalmology with a doctorate in epidemiology, who serves as the director of the Center for Devices and the Radiological Health. She has spent more than 15 years as a medical device regulator, driving strategic initiatives, conducting clinical research, and changing organizational culture. Dr. Tarver has held various leadership positions while at FDA, including Deputy Director of the Office of Strategic Partnerships and Technology Innovation and the Program Director of Patient Science and Engagement. Over the course of her career, she has conducted laboratory-based epidemiological studies, clinical trials, surveys to capture patient preferences, as well as develop registries and patient-reported outcome measures. Dr. Tarver has extensive policy experience in crafting regulations, guidances, and conducting pre-market and post-market review. She most recently served as the Deputy Center Director for Transformation, steering the development, implementation, and direction of CDRH's transformative project and strategic initiatives. Also joining us today is Dr. Sherry Ling. Dr. Sherry Ling is currently the Centers for Medicare and Medicaid Services, also known as CMS, Deputy Chief Medical Officer. Over her career, she has applied her expertise and experience as a gerontologist and geriatric medicine specialist towards improving health outcomes through clinical care, scientific inquiry, and health policy, in addition to a clinician leadership role across CMS. Dr. Ling has represented CMS on several HHS committees and work groups, including the National Alzheimer's Project Act, FACA, Healthy People, Behavioral and Mental Health, Healthcare-Associated Infections, the National Strategy to Combat Antimicrobial Resistance, and Scientific Integrity Council. She joined the Johns Hopkins University faculty for 5 years, after which she joined the IRP of National Institutes of Health at the National Institutes of Aging as a staff clinician for 8 years, studying human aging and age-associated chronic diseases with attention to musculoskeletal conditions and mobility functions. Dr. Ling continues to serve as a part-time faculty member in the Division of Geriatric Medicine and Gerontology at Johns Hopkins University School of Medicine, and serve as a volunteer faculty for Dementia Clinic with the Baltimore VA Medical Center. I would like to start off by Dr. Cheng on addressing the partnership and government facilitation. So Dr. Cheng, as the director of NEI, can you share your perspective on how NIH, specifically NEI, approaches partnerships to advance data standards?
Yeah, of course. Saya, I'm really glad to be here with both Michelle and Sherry, and totally looking forward to this. Maybe if it's okay, because I think the key to answering your question, you asked about approaching partnerships, to me, the key is identifying what was the problem we were trying to solve. And I just want to emphasize some of the points that Amber made in her introductory remarks. I think they're really important. One of the fundamental issues is that in the field that I work in, ophthalmology, images are the basis of modern care and modern research. These images are generally are generated from devices that sit in eye doctors' offices. They're generally, $30,000 to $50,000 devices. They're used often for every single patient. You'll get image, and in ophthalmic practice wasn't like that over 20 years ago, and this is a relatively new thing. And as Amber mentioned, the problem is that we can't get raw data out of these devices. They're locked in proprietary standards, and that causes huge problems with clinical care and with research. And the good news is that the DICOM standards exist, and we know that there's a roadmap for doing this because the radiologists have done it. And these devices have been plug and play for decades in radiology. But these standards are not adopted consistently by the companies. And the other thing I would just emphasize from what Amber said is that we have written white papers like for the last 15, 20 years, and nothing changed really. And so that, I guess that's Syed, the best way I would begin to answer your question by, when I started this position, we really felt that there should be some role where government can help move the field forward, because I didn't see it happening by itself. And that's how we ended up finding, partners, in this case with the FDA and with what was then called the ONC. So I'll stop there.
Yeah, thank you very much, Dr. Chang. Same type of scenario and question for you, Dr. Ling. From CMS perspective, how do you see government agencies balancing their dual roles as regulators and facilitators when partnering with external organizations?
Yeah, and also adding my thanks for the invitation to be part of this panel today. Really appreciate the invitation. And to also respond to your question about, the government's role. So as an agency, CMS is very much an implementation agency that builds policies, including that of payment and coverage and clinical standards based on the available evidence, right? And importantly, as we implement, these are authorities that the agency has been granted. So they are very much so dependent on the evidence, which also means dependent on information, on the data, and they're not necessarily all can run parallel, all can run in synergistic ways and in non-competitive ways. I think the ultimate question is what's the most appropriate policy or program lever to utilize for which purpose to solve which problem. And so, there's a role for CMS as a regulator, and really that of regulating facilities. There is not a role for CMS as a regulator of clinical practice. In fact, there's a prohibition from that. And there's opportunity to implement coverage determinations that are very much built on available evidence, and also call out where evidence may be promising, but insufficient as it applies to the population of beneficiaries that the policy would apply to. So I think these are not mutually exclusive, nor a complete list of the roles that CMS plays as a regulator, as a facilitator, as contributing to standards for different purposes, but very much appreciate the interaction with our federal and HHS colleagues to actually synergize even further to improve the health outcomes for the people we serve. I'll stop there. Thank you.
Thank you, Dr. Ling. So, Dr. Tower, from your perspective as the director of the Center for Devices and Radiological Health, how does FDA navigate the challenge of maintaining regulatory standards while also encouraging innovative ways to incorporate data standards through partnerships.
So first, I'll say thank you very much for the kind invitation, and Amber for a wonderful summary of the effort. I'd also like to acknowledge some of the folks at CDRH that were actively involved, including Dr. Edelman, Dr. Nguyen, and Dr. Heng. One of the things that I'd like to first highlight is the fact that data is the lifeblood of the work that we do. It is the foundational premise on which we generate evidence that can inform regulatory decision-making. When it's done in a standardized and well-conducted way, it's information we can rely on. And, you know, sometimes people question, well, if you put all these standards in place, will you stifle innovation? And I would argue that having clear and predictive expectations for the parts that don't need necessarily the creativity will allow innovation to thrive, because there are certain things that you don't have to figure out. There are certain things that are already kind of laid out for you. And that is what I think these government partnerships have helped to foster. It helps us to set forward standards that if you do it this way, we know that it'll work across our spaces, and collaboration allows that to happen. We have conversations one with the other. You know, we've worked in collaborative spaces both domestically and internationally across the center, because standards helps the manufacturers who are creating medical devices to come to us with clear expectations of what's going to work and support a regulatory decision, an authorizing decision. And that is effective mainly because we don't exist only in a domestic arena. We have global partners, and manufacturers generate and distribute globally. And so when they understand what can be done consistently, it helps to create predictability in their development pathways. The other thing that I would also mention is that, you know, I'd be remiss if I did not mention the unique device identifiers. While we are talking about ophthalmic devices, unique device identifiers, which allows us to understand specifics on who manufactures the device, what version of the device is being manufactured, what's the serial number, what's the expiration date, all of that information is contained in a unique device identifier. And as we are looking to see ways that we can look at traceability of a device over the life cycle as it interacts with various different patients and detect whether there may be some performance or safety concerns, or even the opportunity to expand labeled indications, UDI is critical to that, and its incorporation not only into the medical product itself, but also into the electronic health records, into the claims databases. All of these opportunities allow us to leverage information so that innovation is not just about product development, but it's also innovation that can help expand access to various populations.
Thank you, Dr. Tarver. You know, in this session so far, you know, what we have been hearing so far is the great value of data and metadata that is needed, not just in ophthalmology, but throughout the different medical fields themselves. Amber even shared about the need of ocular imaging standards, as well as challenges for retrieving imaging data from devices. So again, a question for you, Dr. Tarver, as to what were some of the challenges that FDA encountered while encouraging industry to adopt ocular imaging data standards, and how were these challenges addressed?
So, I mean, I think we're dealing in a business case world, right, where it has to make business sense. And sometimes the adoption of standards may require an additional investment. So I think that is one of the challenges that industry has faced with respect to adopting certain standards. I'd say another thing is that the infrastructure in which some of these devices are, particularly the imaging devices, how they interface with electronic health records, there's so much variability on that infrastructure space that it's hard to create solutions that will work for everyone. And so I think there's got to be an appropriate matchup for it to be worth the investment, and a guarantee that it can be integrated into various different systems without the need to customize or tweak or adapt. And I think that has been one of the challenges, I think, for uptake. And then everybody has different priorities, right? when they're coming to submit their device to me for a regulatory decision, or our center for a regulatory decision, their drivers and their priorities for how they develop their device are different because they're trying to get through our gate. And there's multiple different gates in terms of the healthcare ecosystem. There's the payer space, there's the provider space, and then how does it integrate into care? And I think when we all harmonize together on what our expectations are, then it can help push the vendors to develop. And in my case, I call them the medical device industry because I think of vendors as the electronic health records. But I think all of these groups need to talk together in order for us to have fluid collection of data so that we really can have the optimization of information to expand not only care paradigms, but also expand labeled indications for medical devices.
Thank you, Dr. Tarver. Dr. Cheng, so as a director of NEI and as an ophthalmologist as well, can you walk us through how the FDA, ONC, NEI project on ocular imaging standards adoption came together and the key factors that made it successful? And you have been deeply involved in all these efforts. So if you could share more about this success story.
Yeah, Syed, happy to. I think as I was listening to some of the comments that Sherry and Michelle made, I would like to just start by calling out a few of them that I thought were really important. One of them is that, doubling down on one thing that Sherry said, I don't think anything is specific to the ophthalmology field. We're talking about ocular imaging, but I think every field has an equivalent of some device that doesn't talk to other devices. And the other thing that Michelle mentioned about collaboration and this barrier to innovation, I completely agree that I've never heard anybody argue that having everyone use the same plug into a wall or use the same HTTP protocol to get on the web is a barrier to new ideas. I really think that was a good comment, a great comment about the business case world. I think, Michelle, was your comment that I feel that we are in a world where the people doing the work have incentives to move quickly. And as an investigator, you want to publish papers quickly. And our goal in government is to move the field forward and to advance the field. And I think that one of the challenges of this is not that we have bad people, but we have people who have different things that are driving their behavior. And I do think that's one role of government, that we can help drive behavior to move toward the goals, presumably that all of us want, which is to advance the field. But I mean, as a investigator, my job was to advance my career. People told me I had to get tenured and write papers, and I think there's a difference in that. And I think that's with that. Syed, you asked about how this came together. I really felt that carrots weren't working because they hadn't done anything for the 20 years that I was in academia. And the question was, what can we do in government to help create those levers, it was Amber's word, to move the field forward. And for us, we fund grants. And my vision was that I don't want to be funding grants if they use devices that aren't conformant with standards like DICOM, because I don't think that's how we are going to do the best research to move the field forward. Nobody's going to collaborate if these devices can't talk to each other. We're going to continue to have one-offs and siloed projects. And frankly, that's not the way we take the best care of patients. In the academic department that I worked in, we have these ophthalmic PACSs, essentially image management systems, and we had 2 of them, because not all the PACSs could talk to all the different devices, and that was often vendor driven, and so the way, Syed, to finish answering your question, the FDA was a great partner because they regulate imaging devices. And the ASTP was a great partner because they regulate electronic health data exchange. and they are experts in compliance. And as Amber mentioned, we engage the professional societies, the VA, key industry players in planning and in speaking. Put out an RFI to the community. And after the workshop, the two professional societies, the Research Society and the Clinical Society, wrote a joint position paper saying that we really need to do this. And I guess in summary, I would say that just to emphasize one thing that Amber said initially, that I think that I think it's premature to call this a success. I mean, we've moved forward, but I think that we've to the extent that we've succeeded, it was because we got all the stakeholders together and came up with a unified goal.
Dr. Chang, you brought up a great point of how important cross-agency collaborations, as well as involving all the different stakeholders, that includes industry, academia, government agencies, is crucial to the integration and really using the best standards of moving the field of data standards and meta standards forward. On that note, I have a question for you, Dr. Link. Are there any specific examples from CMS where cross-agency collaborations have been particularly effective in adopting data and metadata standards?
Yeah, good question, Saeed. I mean, we have so much work underway, and it's, by definition, it has to be collaborative. And I think one example of a cross-agency collaboration and adopting data and metadata standards is the CancerX collaboration, where we actually created an API to be able to share claims data as one type of data or a data source. I will say it is a type of data that CMS has just volumes of data available. But I will also say these are administrative data that they're informative, but not for the purposes of payment. It's a good tracer or tracker for payment for a condition. Now, having said that, though, I think it's really important to also think about, how do we use the claims data in a much more robust way? Claims and what's documented in the electronic health records can be a very important data source. And we've been making progress in defining what we mean by, real world evidence, considering EHR data and also registry data as different data sources, not just coming from, randomized trials, but really what's happening in the real world, because that is an important bridge between the science and the practice. And it is likely that information, it can be useful for multiple purposes, right? To be able to establish payment, but also for purposes of management and as a source of knowledge and evidence for policymaking. I will also say, though, that as another example, and this is still work in progress, even within the electronic health records, data standardization, what data do you really, really want for multiple purposes? And it may differ between what, as Michelle said, the business case, like what is the disease you're interested in focusing a new therapeutic or intervention on? I will say, I think there's a role for disease-specific data elements, but also in the Medicare population, there's an important distinction between the evidence that establishes if something is safe and effective, and that which can determine whether or not a treatment or service is clinically useful because of the richness of comorbidities that reside in the population of Medicare beneficiaries who we serve. So likely people may have eye condition, but also may have kidney disease. They may have some common causes, but for us to be able to know what are the health outcomes that really will matter across different diseases. So, there's disease-specific outcomes, but also, disease-agnostic outcomes, or that are relevant to multiple diseases. I think that's one of the areas of work that we really have committed to, that we have to continue. And we cannot do this, in isolation, even as a payer. Over.
Thank you, Dr. Ling. Dr. Tarver, can you share from your experience at FDA as to how some of the other data standardization initiatives within your agency worked, and just share some success stories as well?
Yeah, I mean, standardization for data is really important for a number of different reasons. I mean, you've already heard us allude to the importance of traceability of medical devices so that you can look at performance and you can look at whether there's opportunities to expand the label indication when a device is in real-world use, because people may use it in a manner that is not on label, and it may offer opportunities for you to see benefits in certain groups, or tailor the treatment protocol in certain treatment approach in certain groups. And so there's an opportunity there. And I think you heard Sherry allude to the importance of common data elements and how we define things and all the metadata that surrounds that allows it to be robust enough that it can be regulatory grade. And so there's a lot of work happening where we have partnered with various groups, federal agencies, private organizations, as well as collaborative communities. There's one on collaborative community of ophthalmic imaging, at least that's what it was called. It's evolved its name now, but it was really focused on how do we work on data standards that can be useful in the ophthalmic space. The other thing that I'll just plant a seed, which is, we're really talking a lot about medical devices that are used in a clinical or healthcare setting, but we're increasingly seeing these technologies move into the home. And so to be able to have a fluid transfer of information that may be collected in the home setting by a medical device that's collecting images, because we're seeing a lot of those, and then integrate that into an electronic health record so that a provider can make an informed decision, is going to necessitate some data standardization approaches and interoperability, quite frankly. The other thing I will say as a success story is that we have worked with other groups. I talked about the UDI a number of times. If you didn't get it at the end of this talk, please use the UDI, integrate it into what you do. It really is going to be a way that we can trace medical devices. And we've worked with various partners, collaborative efforts, collaborative communities, and UDI as well. Because as you said, no one entity can do this alone. It really is going to include all the folks that you've mentioned, but also I would put in that mix patients, because they're increasingly leveraging their own data and using it to help inform some of their healthcare practices. And there is an opportunity as we look towards the future for these consumer tech and medical tech to talk together. And if you have good data standards that allow for that integration of information, I think we can move the needle forward in terms of healthcare. And we're already exploring those conversations with other groups.
Thank you, Dr. Tarver. So we do have two questions from the audience. The first question is, what best practices can partnership adopt to promote transparent data sharing protocols that facilitate reproducible research without compromising data integrity? And any of the panelists can respond to it.
Syed, I feel like as I think about that question, I'm hearing two parts of it. One of them is the data integrity part, and the other is promoting data sharing. And let me just try to speak a little bit to each of them. Data sharing, I think, is a huge challenge. Like, if we're really going to do research at scale, we have to share data. And everybody knows that. That's what team science is all based on. And I don't think we have an ecosystem that promotes that. individual investigators are disincentivized because in the scientific culture, you are rewarded for doing something on your own and for being senior author and for doing it first. So that's just the world that we all grew up in, and the world that we live in now. And as much as we talk about data sharing, what I'm hearing from the community is that nobody wants to do it. And if I really pare down the layers of the onion as to why people don't want to do it, I think what's happening is that they don't want to help their competitor beat them, with their own data. And most people don't say it so bluntly, but I think that's what is happening. And so one of the things we have to do, I think, is to make people feel like they benefit from sharing data. And here I have to promote something that that really Amber and Syed are helping to lead, which is what we've been calling a data sharing index, or S-index challenge. It's basically a challenge competition. Amber, thanks for putting in the box, to develop a metric to reward people for sharing data and for sharing good data. Because I think having those carrots and making people, these are some of the smartest people in the world. And if they want to do it, I really think that they'll figure it out. But right now, there's not an incentive to want to share. I'm going to stop because I'd rather listen to Sherry and Michelle talk about the other part of that.
So this is Sherry. I would say, additional best practices that would help achieve clarity in the evidence signal is going to be, as you're engaging in conversations about data, to be as clear as possible about how do you want to use the data and what do you mean by the data. Even a single data element can have various interpretations. And we see it all the time, which can result in confusion in the translation across studies and also across research into practice, and certainly to take the next step, which is to policy for payment purposes and for coverage purposes. I think it's also good practice to be very clear about the population that you intend to apply the treatment or the policy towards, because you may be missing important determinants of the outcomes that you're seeking. And, there, as I said before, there are disease-specific outcomes, and there are also much more general outcomes that really matter to the people who would be receiving the treatment. And it may be that there are other factors, other diseases that might determine what those meaningful outcomes are, independent of the disease-specific outcomes. And the final point I just want to make is, especially when it comes to how we look at the data and the incentives for reporting data, how we use the data, including quality measurement, which is in and of itself can be either a carrot or a stick, depending. I think it's really important to note who's missing from the data. And one request I will leave you with is, when it comes to treatments and services that you hope Medicare will be supporting and covering, please include older adults and people who look like Medicare beneficiaries in the samples, because otherwise the findings may be promising, but without sufficient information to determine how useful a treatment or service might be. So thank you so much. Over.
Thank you, Dr. Lang. I would like to just conclude by getting Dr. Towers' comment.
I'll keep it very pithy. So data is increasingly being used to develop medical devices. As you see, most AI-enabled medical devices are reliant on good quality data. So as a result, it has a high price point. And so there is a business case for why data isn't being shared as well. I think, though, that in the interest of creating robust technologies that can learn from data, sharing is going to be critical, because nobody can own all the data that's ever generated by any particular product or help improve that product. And so I do think that, to what Dr. Chang alluded to, opening up the doors and understanding that we all can learn from it and develop better products that will help improve public health is really important.
Well, I just wanted to thank all the esteemed panelists for joining in today. And with that, I'll return it back to Rebecca. Thank you very much.
Thank you. That was excellent discussion, and thank you. It really, really highlights the role we all play in moving this field forward. I am going to bring up our last session, which is gonna tie it all together in a nice little bow. And I'm gonna introduce the session chairs and these workshop chairs. I'm gonna start with introducing Dr. Danny Gossett, Dr. Gregory Germino, Dr. Ravi, are you gonna forgive me because I cannot pronounce your full name, and Dr. Shujin Wang.
Thank you. So, Rebecca, at this point, do you want me to take over and lead the discussion? Oops.
Yes.
Oh, wait a minute. Yeah, there we go.
Please,
My camera's
we're gonna
showing us.
have our, title together and our concluding remarks.
Great, thank you. So thank you again, Rebecca, for the introduction, and again, thank you to our panelists. As you know, we're coming to the end of the two-day conference. We have we've covered a number of themes, and what we would like to summarize, we're going to show here on this slide and on the next, a number of different sort of salient points that people have captured from our panelists here. And then we'll go engage in a conversation, a brief conversation, as we think about what the future might hold. And so on this first slide here, you can see some of the summaries of some of the things that we've gathered. And so one, we heard presentations that covered the aspect of standards and how sometimes there need to be compromises to accommodate the needs of the many users. If we're going to have standards be implemented broadly, they have to meet the needs of our many people who need to use those standards, or else they won't be taken up. And so if the goal again is broad reuse of information, broad participation by the community, we have to figure out again sort of the sociological aspects of dealing with groups. And so making sure that the standards are something that people can embrace and use easily is important. And that is what the second point also covers, which is we need to anticipate not only standards that can apply to meet everybody's needs, but they need to be able to use these easily. The lower the bar for access, the more people will use them and comply. And so that's an important consideration in thinking about standards that would be applied. We heard a lot about what the benefits of standardized data can be and how this can really enhance our science and enhance the discoveries embedded in the work that all of us do. And so this is, again, an important reason why we're having this workshop, is to get to that future state where really it's part of our standard practice that all of our information is captured in a way that is reusable by everybody else. We have heard about our large consortium, how they're identifying the crucial metadata, but they highlighted one of the challenges, and that's with having a group of people achieving consensus. How do we get collaboration across the parties? In some cases, we heard where it seemed again, it was the community came together. We heard, I forgot the name of the tool that we had heard about yesterday. There was one that particularly it was a consensus from the community to work together to develop something, a standard that was very easy to use, and people have adopted it. Some of the other fields, we know that this is not quite yet the current state. And so we need to think about how we can get, again, community buy-in. It's clear that we need to capture the metadata from the beginning. And we need to be sure that we use existing ontologies and controlled vocabularies to ensure data convertibility. Again, it gets back to the standardization process and standardization issue. And then finally, as we just heard in the last session, it's really important that we get people to share their data. And as you know, and as I introduced yesterday, NIH is really committed to this. We've put it into our policies and into the terms and conditions of all of our awards that individuals that are investigators will have to submit data management and data sharing plans. And so we, again, expect that this will hopefully begin to change the culture of sharing, the expectations for sharing. So I want to stop at this point just before we go to day 2 and ask our panelists if they have any thoughts that they want to add to the summary from day 1 and any additional thoughts on this. And I'll start off with Shijing.
Thank you, Greg. Yeah, it's a wonderful 2 days. This is a very good summary, this slide. If I may add something, I guess maybe I'll specifically comment on diabetes. A point actually I heard from my colleague Gilmore Aziara Rubin is the fact that diabetes is one of the most common chronic conditions, right? We all know that. But however, probably more so than most of the other chronic conditions, it has the potential really to combine data from multiple sources across multiple modalities, whether it's insulin glucose or behavioral lifestyle factors like meals, exercise, sleep, etc. And toward optimizing a personalized care and management. The field itself, I mean, diabetes care and management is super data intensive and technology intensive. So it's also a field that can really benefit tremendously from having unified standards. Related to diabetes, I thought to also comment that various speakers mentioned specific examples that demonstrate how having data standards, at least a minimum set of data, common data elements, common data models, etc., can really improve clinical practice and can be very helpful to preclinical research. I thought to comment that it's also going to be very beneficial for everyone in terms of self-management to stay healthy, to prevent developing chronic conditions, etc. Yeah, I mean, that's my takeaways from day 1. Thank you.
Thank you, Shijing. Ravi.
Thank you, Greg. So as we know now, we have been hearing a lot of feedback. So the common consensus is actually we need data standards, absolutely. But there is some kind of perception. Because AI is there, we don't need a standards now, because AI can fill that space and AI can automatically make the AI can automatically enable the interoperability. So that's some kind of misconception going on now. But as Shankar noted yesterday's presentation very clearly, regardless of whatever the advancement we have, whatever we are junk in, junk out, because AI uses the data is as good as it's actually is going to be, the output actually. So output is going to be as good as just the input. So regardless of whatever the AI's power, we still need some kind of annotated, standardized data so AI can understand and, so understand and, to give the results. So that's actually a very important point to note it out, regardless of the advancement, we still need to work on this enabling the data standardization. yeah, I'll stop there. I'll come back then. Thank you.
Thanks, Ravi. Danny.
I agree with the points from my colleagues. I think I'll just add that while some of the data types that we've heard about may be ahead of the curve, the path has really been paved by our colleagues from other domains, and there are opportunities to lift all boats, particularly in the areas where there are intersections between disease domains, and there'll be opportunities to look across multiple chronic conditions to learn more about these diseases and opportunities to develop treatments, better care.
So I have a question for all three of you now. And so, we heard about the importance and necessity of having standards. We've heard from Ravi that maybe this will become, AI will help solve this problem for us in the future, or simplify the problem, certainly. But we're not there yet, and may not solve all of our problems. But one of the things we did here, and it's kind of summarized here on the salient points for day one, it'll be on day two as well, which is, in some fields, in some areas, we've seen the community come together, and they've been able to sort of self-assemble and decide what some standards should be, and they've kind of embraced that. We also know, we've also heard that it probably isn't the role of the government to say, these are the standards that we're going to make you apply. And yet, how do we get the community to, when there may be different, again, no consensus, how do we get to a consensus that we can then embrace and endorse without having it as a requirement that you must do X or Y in our notice of funding opportunities or whatever else? What do you think?
So very quickly, Greg, I mean, standardization process is a community process, right? I mean, we cannot just enforce or say anything about, this is how we should be doing. This should be spontaneously developed by or coordinated by the communities. That is the problem. Sometimes, when we organize, you say, this is what, we are building the standards, you come use it. That's not how it works for the standards. It should be coming from the community. They build it, and then it will enable this interoperability. So that's why sometimes, where some places, they have some in silo standard development without knowing others, that is the main problem here is actually lately. Everybody's having their own data standards. They're developing advancement, whatever it is, without knowing others, that lacks interoperability. Even, that's making their own data domain, interoperable. But again, they cannot just go outside and collect the data outside. So that is the need is the big federal government. I mean, we can just to federate this actually development, by embraced by the community. We cannot be other way around. We cannot dictate or say that, this is what the standard should be, this is how we are developing. So I stop.
So Greg, I thought Dr. Subramanian yesterday made a very good suggestion. That is, the community have a lot of interest to come together to probably address the challenges in data standards. Communities are ready, and a lot of them are actually ready to do it on a voluntary basis. So, I feel us, federal agency, like Ravi said, we cannot mandate people to do this way or that way, but we can facilitate, we can coordinate, we can help the community to accelerate this process of reaching some consensus or agreement, right? We can help community to form working groups, as Dr. Subramanian suggested. We can provide incentives for people to adopt, to use, and probably to develop use cases. I think there's a lot of things we can think about to, as I said, to facilitate, to coordinate, to accelerate, and to incentivize. Yeah, over. Thank you.
Thanks. Dr. Subramanian, please.
Thank you, and I apologize for interfering, but I just first want, I just first want to say that this was an outstanding effort from NIDDK. I want to thank Rebecca Ravi and Shujing for really organizing this. A lot of interesting points came out of this. I want to extend the comment that Dr. Germino brought up just now. Number one, there are several efforts across NIH towards building some kind of standards. And you're probably familiar with this. Common Fund data ecosystem now has integrated all the Common Fund, about 20 Common Fund data sets. We have a common, I lead that effort. In fact, we have a common metadata model for that, for the omics data. We're starting to build one for the clinical data. We are talking to NHLBI Heart, Lung, and Blood with Shweta Ladva in terms of trying to integrate their biodata catalyst types of metadata information. And we would really love to do this so that there's some kind of acceptance from the community broadly, and you can help facilitate some of these. And we heard a very exciting stuff with reference to the clinical metadata, both from Ravi and from this morning on policy levels. I really think, again, NIH can facilitate the process of bringing people together, institutions together, and companies like Epic, which are serving electronic health record systems, they also care very much about standardization, or at least providing tools for standardization, which can be used for cohort building and so forth. I was speaking with all of us folks, and all of us can lead an effort in terms of kind of helping in terms of nurturing this notion of building clinical metadata that would help in terms of harmonizing data efforts. So just a suggestion and a thought for all of you folks to think about. And I think it'll help us along going forward in the community.
Thank you. But one of the challenges, right, is, we've heard, as we heard yesterday, and I think this morning as well, is how do we go from having 14 standards to 15 standards, right? By now bringing people together and getting another whole new standard that is, may or may not be better than what we've had before.
Yeah, I think really at the level of the molecular level type data, there is starting to be convergence across the standards. It is not as divergent as in the disease data. There are, of course, things which are, ontologies which are providing some kind of a structure in terms of how we want to go about SNOMED CT and RxNorm, LOINC. These are all good efforts in terms of trying to create some kind of a community level standards. There's always going to be some ambiguities, some kind of a discord in terms of presentation, but there is beginning to be the realization because of AI, as Ravi pointed out, if everybody wants to feed things into AI, you need to have some common ground for doing it, which is what motivates a lot of us, a lot of communities to really come together in creating standards. And my last point, I apologize, last point I'll make is that even if there are different formats, if we can provide the APIs, application programming interfaces and tools to convert into standardized formats for harmonizing, that would be a good way of going about doing things. And this is something else the community is trying to do now.
Thank you. Danny, you have anything you want to add to this, or Shujing or Ravi, do you want to respond to that, or?
I absolutely agree with Shankar. He has been doing this for a long time. He knows what he's talking. So that's why. And also, Shankar, to add up on that, we need to make sure the distinction between the semantic standards versus the syntax standards. There's always a confusion about it.
Yeah.
Misintegration. And so there's like kind of misleading. Yeah. Thank you.
Yeah, completely agree with you.
Thanks. Shujing, Dan, yeah, sorry, Shujing.
Yeah, I just a quick comment. I'm somewhat optimistic toward this challenge. I feel the technology is advancing and converging, and the community has high interest. A bunch of factors from what I can see probably are converging, and it's hopeful the community probably will reach some consensus, and a winner or combined version of the 14, 15 sets of standards probably going to happen. But if we can think probably proactively to catalyze this process, it probably can happen a bit sooner. Yeah.
I agree, and I don't think that we necessarily need to predict which approach is going to win out. I think we can be a convener seek to identify convergence of incentives from the various groups and help them along the way, but don't need to anticipate which route is going to be the most successful.
I mean, certainly, I think to build on Zhujing's optimism, if we look even how we've come since 2004 when they started developing health information standards, and the expectation, even just kind of a vision that we might have electronic health records, right? I mean, we still have a long way to go, perhaps, to be in the optimal state, but it really has improved and is accelerating. And I think, to your point, that when everybody starts to see that that there's the incentive to get to a better state is now shared widely, and the technologies are improving to do it. And there's clear utility by getting things linked up. I think those drivers are likely to accelerate progress rather than to continue to have things fractionate. So why don't we move, unless there's any other comments, we can move to day 2. And a lot of the same themes, as you can see, what you'll see in a second, were brought up in day 2. We heard about leveraging traditional technological approaches and how that requires shared semantic alignment and mapping for this to occur. The theme you just spent a few moments talking about, which is the need to work together and reconcile efforts to promote harmonized person-centered data, and then to get people to adopt these standards, and then again, how to make sure we continue to move this along. And we've just spent a few moments discussing this already in our discussion of day 1. We just heard in the last session from Dr. Cheng, the efforts to go from, at least in the NIH process, of using sticks, like you must do this, you must share your data, you must put your data in a way that others can use it, to figuring out how to improve the incentives so that people will want to do this and want to, again, think from the very beginning of planning their project in a way that their data will be able to be useful by others. And importantly, given that as we think about any of our research, including patients, particularly when we're thinking about clinical research, we need to be sure that they're helping us as partners in this. And then particularly as we think about increasing the number of home technologies or home measurements. So not only the ethical issue of making sure that they're aware of what we're doing with their information, but having them, as we have them as research partners, making sure that they understand and can input on provide input on how we gather information from their personal space, their personal home environment. We heard a bit about how AI and federated approaches and learning health systems can drive dynamic integration and characterization of common data elements and the clinical research, and also can be useful in improving health care outcomes. Again, another use case of just how important and impactful all this can be as we improve our standardization and use of CDEs. And then finally, changes in standards over time do present both opportunities and challenges to the system, and that AI tools may facilitate integration of retrospective data and data from multiple domains going forward. So again, the new technologies are enhancing our ability to use old information and link it with new information. And so that's kind of the summary from day 2. And again, I turn to our panelists to see if they have any additional thoughts they want to add to this, to these talking points on the slide. And I'll start this time with Danny, since I started with him. I went with him last time.
I guess I'll say I was excited to see in the sort of the chat going along through this day in particular of groups that were doing similar things but had not yet been connected. So I think there is a lot of excitement in using these AI approaches to take advantage of the opportunities that are outlined in these points here. So as Zhujing said earlier, I'm optimistic. I think this is a very exciting time.
Great, thank you. Zhijing.
So first, apologies, I missed a lot of day 2 talk because I have several other obligations. But I was able to join around the lunchtime. I heard the 2 talks, one by Ravi and the other by another speaker on AI technologies. And then I saw Shankar's comments in chat. So I want to comment on the second from last bullet item. I guess I probably, like Shankar suggested, would add knowledge graphs, like what Ravi just said a while ago about standards. There's a syntax standard, there's semantics. A lot of it has to do with representation, finding the right representation to present your information, to standardize the way you present whether it's data or information. So knowledge graph is a graphic presentation. It does offer another dimension of how we present information and perhaps how do we standardize data and data elements and how we present information. Yeah, over. Thank you.
Thank you, Zhijing. Ravi.
Yeah, I mean, I see AI is a real blessing here. For us, we can do so many things. Actually, if you asked me, Greg, like 5 years ago, I would have said the same thing. We can do this interoperability kind of stuff. But I am really optimistic, like everybody else. I'm getting really optimistic because, it's like, it's amazing. It's amazing because we can bring all together in one place where we are building the infrastructure that actually avoids so many duplication and so many confusion, commotion, everything. So if anybody wants to see what is available elsewhere, I have to go everywhere and see, even for my IBD specific CDs, I don't know what else is, what's not. So this is why instead of going everywhere, I want to go one place and see if what else there, and then I can work on only if it's not there. Or any, dynamically embedding my CDE for appropriate data elements. So beautifully, we can just do everything in one place. That's why, we were proposing the embedding model. And coming back to Zhijing's point on the knowledge graph, yes, I agree with you, Zhijing. I mean, the knowledge graph actually takes a lot of while because it takes a lot of manual intervention also. But if you we can build this knowledge graph based, kind of interaction knowledge graph based upon the embedding model also dynamically if you have little manual intervention. But alternatively, we can bring the whole knowledge graph combined with the embedding model that will like a double whammy. So that's what I'm saying. We have so much technology advancement there. And then imagine about this agentic AI, so much every agent can do one option, and then we have the MCP. I showed last time, MCP can just federate the dynamic update of all the data, CDE or whatever the data coming from, into the central reservoir. So I'm very optimistic now. The AI is a great blessing. So we can do much better using AI. I think we are, in a few years, we can see this real benefit of this AI, and particularly in the data interoperability. I stopped.
Thank you, Ravi. Any final comments from our panelists? It's great to hear ending on a very positive note. It's a great way to always end a conference and a workshop, and I think it just speaks to the excitement that the community has and about the potential and the tools, and I think the will, now the awareness and the will to move forward in this new space. And really to completely realize the full potential of the research and not only the research, but the real world experiences, right? To be able to integrate that and leverage all of that for discovery is really just unprecedented opportunity. So in closing, before I turn it back to Dr. Rodriguez, I just want to again thank our panelists who also have been our organizers. I want to thank our many, many speakers today and yesterday for the really thoughtful presentations and provocative, and again, highlighting both the challenges and the opportunities that we see going forward. And finally, I want to thank all of you who have participated these last 2 days, because you're going to be important parts of actually implementing these strategies going forward. We really need you as ambassadors to help this happen. And with that, thank you, and I turn it over back to Dr. Rodriguez.
Thank you, Dr. Gemino, and thank you to all the organizers and all the planning committees that work so hard to put this together, all the speakers that came and volunteer. I want to thank also all the people, all the attendees that stuck with us throughout these 2 days. I thank you all for attending. Thank you, and I'll see you next time. All the videos and the also the slides will be made available. So stay tuned for when those will be shared with the public. Thank you, and have a great rest of your day.